طيب. تمام. طيب، بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. Good morning, everyone. It is my pleasure to welcome you to the second day of the 5th Annual Precision Oncology Conference. Today is going to be a unique day as we will be speaking about GI oncology. Then we'll do a live molecular tumor board session. Then we'll end up with a GU and gynecology oncology session. Now, without further ado, I'd like to introduce the moderators of the session 3, which is the GI oncology session. And it's my pleasure to introduce my colleague, Dr. Ashwaq Al-Alayan, Division Head of Adult Medical Oncology in National Guard Hospital, Dr. Ibrahim Madkhali, a well-known medical oncologist from Jizan, and Dr. Fahad Al-Miqbil, also a very well-known colleague who specializes in GI and GO oncology and practices his oncology at King Faisal Specialist Hospital and Research Center. Go ahead.
Assalamu alaikum. Good morning, everyone. Thank you, Kanaan and Muhammad, for having this meeting. And it's not better to start except with GI. It's my favorite topic. And we have our first speaker, Dr. Ali Faqih. Dr. Ali Faqih is a medical oncologist at King Fahd Medical City. He will talk about the evolving role of immunotherapy on colorectal cancer. Ali, the floor is yours.
Assalamu alaikum and good morning, everybody. Thanks, Dr. Ashwaq, for the nice introduction, and thanks for the organizing committee for the invitation for this great meeting, Dr. Kanaan and Dr. Muhammad Al-Garni and Dr. Ashwaq. So my topic today will be the evolving role of immunotherapy in colorectal cancer. So we all know that there are many factors that influence our treatment choices for colorectal cancer, including patient characteristics, tumor characteristics, molecular factors, and patient preference. In terms of the genomic markers of colorectal cancer, the majority of mutations are BRAF mutation. There are a small percentage of patients, they have MSI high, Pol E, which are the most immunogenic mutation, which has immune sensitivity. For microsatellite instability, it occurs in about 15% of early colorectal cancers and associated with a good prognosis in the early stage, while in metastatic setting, it's compromised about 4%. And as we all know that MSI high is associated with exceptionally high mutation burden. As the mutation burden increase, the immune sensitivity increase. This is seen in MSI high and also Pol E, Pol D mutation as well. In terms of the stages, MSI versus MSS stable, stage 2 associated with better prognosis when they have MSI high, while stage 3 and stage 4 disease, MSI high is associated with worse prognosis. The proof of concept for efficacy of immunotherapy in MSI high or mismatch repair deficient colorectal cancer was shown in the previous trials, which included nivolumab and pembrolizumab, and the combination as well, nivolumab, ipilimumab. And in these studies showed that impressive result in patients who previously progressed on previous line of chemotherapy. This is a well-known study which established the role of pembrolizumab in MSI-high tumor, showing impressive objective response rate about 40% as compared to 0% in those patients with microsatellite stability. The role of immunotherapy in first line also has evolved, and the first study, which is the first study, which was the Keynote 177, where patients with MSI-high tumor metastatic stage 4 treatment naive were randomized between pembrolizumab versus investigator choice of chemotherapy with biologic agents. And we all know the result that it has showed impressive improvement in progression-free survival for pembrolizumab as compared to chemotherapy, with also prolonged duration of response. So this immunotherapy is associated with durable response as well. So in the initial phase of the treatment, initial 3 to 6 months, we see an initial drop of patients who received immunotherapy. And there are many theoretical explanations for this, but the most important explanation is a misdiagnosis of MSI-high tumor, where patients with MSS stable were included in this study. This study, they didn't do central review of pathological examination for MSI. The other explanation is pseudoprogression, and also there are some cases where primary resistance to immunotherapy. Okay, this is just showing you the subgroup analysis, which has early progression. So the 5-year overall survival data was also updated, showing also improvement in the overall survival for patients who received immunotherapy 77 months as compared to 36 months for chemotherapy. So now pembrolizumab is the standard first-line treatment for metastatic colorectal cancer with the MSI-high tumor. The other study, Checkmate 8HW, where nivolumab plus ipilimumab was compared to chemotherapy. The third arm also was the monotherapy nivolumab. So this is the initial presentation of the comparison between combination immunotherapy versus chemotherapy. Again, patient with the metastatic stage 4 MSI-high colorectal cancer, randomized between the 3 arms, either nivolumab monotherapy or nivo-ipi versus investigator choice of chemotherapy with biologic agents. The baseline characteristics were well balanced between the groups. And this is the progression-free survival for patients with centrally confirmed MSI-high. As you can see here, the combination of ipi-nivo showed excellent progression-free survival, not reached in the combination as compared to 6 months only in the chemotherapy arm. All the subgroup analysis drive benefit from the combination of ipi-nivo as compared to the chemotherapy. Treatment-related adverse events as compared to the chemotherapy were less frequent. We all know the immune-related adverse events for the immunotherapy. There are about 2 patients who has treatment-related death. One is with myocarditis, one with pneumonitis. So there are some serious adverse events, but luckily they are rare. So the conclusion of the first data showed that improvement of the progression-free survival for the ipi-nivo as compared to the chemotherapy with manageable toxicity and very low rate of grade 3 or 4 immune-related adverse events. So the second publication or presentation is for the comparison between nivolumab ipi combination versus nivolumab monotherapy for all patients who received either without prior treatment or who also received some sort of prior treatment chemotherapy before randomization. And the primary endpoint again is progression-free survival. Patient characteristics were balanced between the two groups. And again, we see improvement in the progression-free survival for the central confirmed MSI high tumor, not reached for the combination. Again, the combination Ipi-Nivo is better than monotherapy Nivo, where a median progression-free survival was 39 months. For those patients all randomized, which include also patients who received prior treatment as well, the progression-free survival was also better with combination, 54 months as compared to 18 months. The subgroup analysis showed also that the treatment favored the combination as compared to the monotherapy nivolumab. Duration of response, and these are the overall response rate, showing better response rate with the combination, especially if you can see here, the complete response 30% as compared to 28%, 40% partial response as compared to 30%. The safety, again, we know that the combination immunotherapy is associated with slightly higher grade 3, grade 4 immune-related adverse events. So again, the conclusion of this study publication, the combination improved the progression-free survival as compared to the monotherapy, with a slightly higher toxicity with the combination as compared to the monotherapy. So now the combination Ipi-Nivo is another standard new first-line treatment for colorectal cancer with MSI high tumor stage 4. There are some cases who develop pseudoprogression in those patients who receive immunotherapy. It's rare and usually early. About 10% with MSI high tumor experience pseudoprogression, and the majority of these pseudoprogression occurs in the first 3 months, and most of the cases occurs with the monotherapy, while it's less frequent with the combination. And it's really important to have the immune resist evaluation for a patient who is receiving immunotherapy. It's important to know that the patients with pseudoprogression are usually well, and those patients usually have clinical improvement, less pain, weight gain, and also improvement of the CA, despite the radiological progression. Okay, the role of neoadjuvant immunotherapy in MSI high colorectal cancer. The first important study which showed the efficacy of neoadjuvant treatment, dostarlimab, which was phase 2 study tested in the locally advanced rectal cancer as neoadjuvant therapy. So the study protocol was to give the immunotherapy followed by chemoradiation and surgery. However, in this study, total of 12 patients completed the treatment with dostarlimab, and all of the patients 100% achieved complete clinical response with no evidence of tumor, and none of them undergoes the surgery or chemoradiation. For the colorectal cancer, we have another neoadjuvant therapy, combination of Ipi-Nivo. This was tested in the NICHE-2 study, where patients received 2 cycles only of immunotherapy, 1 cycle of ipilimumab and 2 cycles nivolumab, 2 weeks apart, so 6 weeks before surgery. Then the patient will go for surgery. The primary endpoint was safety, but there are important secondary objective response rate and major and complete pathological response. So the majority of cases were locally advanced and high risk, and the definition of high risk based on radiology, T4, T3, and N1, N2 disease. So it's about 74% of those patients, they have high risk stage 3 based on radiology. The treatment was well tolerated. Only 4% of patients developed grade 3 or 4 immune-related adverse events. And all patients underwent surgery with R0 resection, and 98% of the patients underwent surgery within the time limit of the study protocol. And the pathological, this is just showing you the definition of pathological response. Any kind of pathological response, 50% or less residual viable tumor. If there is major pathological response, it means 10% or less residual viable tumor, including patient with complete response in the primary tumor, but residual tumor in lymph nodes. Pathological complete response means 0% of residual viable tumor in both primary and lymph nodes. And in this study, NICHE 2 showed major pathological response in 95% of the patient, and complete pathological response in 67%. This waterfall plot showing you this really impressive pathological response. Again, this is just showing you that 95% of the patient has major pathological response rate, 67% has complete pathological response. Only few patients receive adjuvant chemotherapy if they have residual node positive, and only 3 patients receive adjuvant. Other patient either elderly or refused, and none of the patient has disease recurrence with median follow-up of 13 months. There are always questions about Lynch syndrome, and is there any differential response or any changes in the outcomes for patients with Lynch syndrome versus sporadic? And this study showed that there is no difference between the two groups. Actually, the Lynch syndrome has a better pathological response rate. So the conclusion of this study, with only 4 weeks of treatment, we have seen major pathological response in 95% and 67% achieving complete response. The treatment was well tolerated, median follow-up of 13 months. There is no disease recurrence, and it has the potential to become standard of care for deficient, mismatch repair deficient colon cancer. Okay, so the other combination is in NICHE 3 study, which is 2-stage phase 2 trial, combination of nivolumab, but with a new immunotherapy, anti-LAG3, relatlimab, where was a patient with previously untreated locally advanced, again, colon cancer, MSI high, were given 2 doses of combination, nivolumab, relatlimab, 4 weeks apart, followed by surgery, then follow-up. So the baseline characteristics showing that a median age 56, so younger age group, as expected with the majority of cases with MSI, usually in young age. And as you can see here, the T3 patient 58%, T4 37%. So majority of cases are locally advanced. So they say a patient, 100% of the patient underwent surgery without delay, R0 section again in 100%, and treatment was well tolerated with low rate of grade 3 only in 5%, 1 patient only. The majority of adverse events were grade 1 or 2. So better tolerance as compared to the combination of Ipi/Nivo. And again, we see here pathological response in 100% of the patient, complete response in 79%. Adjuvant therapy, chemotherapy was not given for any patient because none of them, they have residual lymph node positivity. So the conclusion of this study, again, we see major pathological response, 100% pathological response, and 79% complete pathological response with good tolerance to treatment. Then the recommendation from that presentation to proceed with the second stage, phase 2, which was done and reported last year. Again, confirming the same finding, major pathological response in pathological response in 97% of the cases, major pathological response 92%, complete response in 68%. Again, impressive result with the combination of this new immunotherapy, relatlimab with nivolumab. Okay, so just a few words about POL-E-D mutations, which are associated with proofreading defect, causes impaired proofreading of the DNA and replication, and this leads to the exceptionally high mutation burden, more than 100 mutation per megabase. It has received tumor agnostic indication for immune checkpoint inhibitor across different solid tumors based on pan-cancer retrospective study, showing high efficacy and response. In colorectal cancer, the POL-E-D are more common in young age, male sex, right-sided tumors, and they are associated with fewer RAS-BRAF mutations. These mutations have higher response and better prognosis as compared to the MSI-high tumor. Question regarding tumor mutation burden in colorectal cancer. There are a lot of questions regarding tumor mutation burden. It received tumor agnostic indication for across all different type of solid tumor with MSI high. However, in colorectal cancer, higher tumor mutation burden associated with improved outcomes with immunotherapy only in patients with MSI high or POL-E. So if you have patients with high tumor mutation burden without MSI high or POL-E-D, they don't derive benefit from immunotherapy. Okay, BRAF, RAS, and high MSI correlation. Again, patient with other mutation, they derive benefit from immunotherapy, and it's not associated with lower efficacy. Okay, what about MSS proficient colorectal cancer? Unfortunately, many trials showed that there is no objective response ranging from 0 to 1% only across different immunotherapy. Okay, there are many strategies to overcome this failure, including using different pathways or combination with vaccines. One of the target is targeting the anti-angiogenesis was tested in this study where patient received FOLFOX bevacizumab followed by maintenance 5-FU beva and atezolizumab. Unfortunately, this was negative. And another study using the combination of cobimetinib and atezolizumab again was negative. And if using anti-angiogenesis TKI combined with immunotherapy also showed some response, but it's very low, ranging from 10% to 20% using different TKI, regorafenib, lenvatinib, and different immunotherapy. There is another way is using intensified chemotherapy combination with chemotherapy immunotherapy. This was tested in the phase 2 atezo-tribe study, where patient randomized between FOLFIRI beva versus FOLFIRI beva atezolizumab, followed by maintenance 5-FU beva and atezolizumab. And progression-free survival was slightly higher in the combination with atezolizumab. However, the overall survival was not different. The subgroup analysis showed that only patients with high immune score they derive benefit from the combination with atezolizumab. As shown here, patients with high immune score, they have median progression survival 21 months as compared to 11 months only with low immune score. So now ongoing phase 3 study testing this combination for patients with metastatic proficient mismatch repair colorectal cancer with high immune score disease. Newer immunotherapy combination. This combination was presented before last year in ASCO using botensilimab plus blastelimab, difficult names, but the short name is BOT/BAL, in patient with MSS stable. So the mechanism of action, the first one, BOT or botensilimab, it has enhanced CTLA-4 inhibition the other one, balstilimab, it has PD-L1 inhibition, and it was tested in patients with MSS, chemorefractory colorectal cancer. Patient received the combination, and the result here showed objective response of about partial response of about 21%. Patient with no active liver disease derive the more benefit as compared to patient with liver disease, and it was associated with lower toxicity rate. And now it's going to be tested in phase 2 and phase 3 study. And I understand that the phase 2 also has encouraging result. So they are going to proceed with phase 3 study. So in summary, the colorectal cancer has two distinct groups based on sensitivity to immunotherapy. MSI high, the Pol E has the high response to immunotherapy. All patients should be tested for MSI and definitely also for Pol E. First line immunotherapy is standard of care for MSI high colorectal cancer. The neoadjuvant immunotherapy is promising and could be considered for select patients. For proficient MSS stable disease, those patients should not receive immune checkpoint inhibitor outside clinical trials. So with that, I conclude my presentation, and thank you for listening.
Thank you, Dr. Ali. It was a comprehensive review. I think we're going to move to second lecture. We'll leave the questions at the end. Our next topic is also an important topic regarding updates of targeted therapy in colorectal cancer. Our speaker is well-known and well-recognized at regional and international conferences, Dr. Kanaan Al-Shammari. He's a medical oncology consultant and GI specialist at National Guard Hospital, King Abdulaziz Medical City, and he's also a director of MENA and NCC in the Coordinator Center. Without any further ado, the mic is yours, Dr. Kanaan.
Thank you very much, Dr. Ibrahim. I think we are waiting for Jason to upload the slides. Thank you, Jason. So I will talk about targeted therapy in colorectal cancer today. This is the outline of my talk. I'll be talking firstly about EGFR monoclonal antibodies, then I'll talk about BRAF V600E inhibition, then I'll also spend a bit of time talking about HER2 agents and what is approved. Then I'll end my talk by briefly touching upon KRAS G12C inhibitors and NTRK therapies. I will not be talking about immunotherapy nor VEGF inhibitors after Dr. Ali Faqih. So these are the targeted options in first-line management of metastatic colorectal cancer. We know that RAS and BRAF wild type, we would consider EGFR monoclonal antibodies. HER2 inhibition is considered in later lines. However, there is a study now in first-line setting. Microsatellite instability, BRAF V600E inhibition, which now should be targeted in the first line, and of course the KRAS G12C story. So this is the ESMO guidelines from a couple of years ago, and it does talk about targeting or targeted therapies in the first-line setting. However, I think it should be updated soon. Now, if we talk about EGFR monoclonal antibodies, of course, we all know we have two FDA-approved agents, cetuximab and panitumumab. Very similar. Probably the biggest difference is that cetuximab is a chimeric agent, whereas panitumumab is fully humanized, and hence, theoretically, infusion-related reactions may be a little bit higher with cetuximab compared to panitumumab. ASPECT trial, a very old study which tested both cetuximab versus panitumumab head-to-head, and it showed no major differences or no clinically meaningful differences between the two agents. As you see on the left-hand side, the overall survival curve, and on the right-hand side, the progression-free survival curve. Now, they were given as single agents in a chemorefractory setting. Now, the sidedness story started a few years ago with the CALGB-SWOG study, where FOLFOX or FOLFIRI were given with bevacizumab versus either FOLFOX or FOLFIRI plus cetuximab. Primary endpoint was overall survival. And as you can see, the overall survival between the two agents was not really different or statistically different. In fact, it was quite similar. However, when they went retrospectively and divided them up as based on sidedness, as we can see, there is clear superiority of cetuximab in left-sided tumors, and it did quite poorly in the right-sided tumors, whereas bevacizumab was a bit similar between the left and right-sided tumors. Paradigm trial was the first prospective trial to test this concept prospectively of sidedness, where FOLFOX was added to panitumumab and FOLFOX was added to bevacizumab as a comparator arm. And as you can see, there was a difference of about 3 months favoring the addition of panitumumab in left-sided tumors. And again, this was tested prospectively. Now, FIRE3 is a well-known study where it tested FOLFIRI plus cetuximab versus FOLFIRI plus bevacizumab. In the left-sided tumors, there was superiority of cetuximab. And what I want to show you here is an interesting subgroup analysis that was presented in last year's ASCO. So for primary tumor sidedness, there was clear benefit favoring cetuximab. However, for limited liver disease, there was also an interesting signal favoring the addition of a monoclonal antibody. And what's interesting here is that in right-sided metastatic colorectal cancer, now remember, this is a subgroup analysis that was done after the study was done. There was a benefit of bevacizumab, and there was a numerical benefit of cetuximab in liver-limited disease in right-sided colorectal cancer. Breakwater, which came after Beacon. Beacon basically established encorafenib as standard of care with cetuximab in or after in later line therapy for BRAF V600E mutated metastatic colorectal cancer. Breakwater was a phase 3 clinical trial that combined this combination of encorafenib and cetuximab plus chemotherapy versus standard of care treatment, which is chemotherapy in the first line setting in BRAF mutant metastatic colorectal cancer. It was an open label randomized phase 3. There were 3 arms: encorafenib cetuximab plus FOLFOX versus standard of care chemotherapy. And the co-primary endpoints were objective response rates by blinded independent central review and PFS. So for objective response rate, there was a clear benefit favoring the addition of encorafenib and cetuximab with chemotherapy in the first line setting. In fact, the difference was more than 20% for objective response rate. So 60.9% versus 40% for chemotherapy in such group. Now, if we look at the overall survival, the median overall survival at the time of reporting the study was not reached, whereas the standard of care chemotherapy in metastatic colorectal cancer, that is BRAF V600E mutated, was only 14.6, indicating that this is a very aggressive subtype of colorectal cancer that carries poorer prognosis. So the investigators' conclusions was that this data supports the first line use of encorafenib cetuximab with the addition of FOLFOX as a standard of care treatment for BRAF V600E mutated colorectal cancer. And basically, this resulted in an accelerated FDA approval that was launched in late December of last year. Now, the HERS2 story is a variable story because overexpression or amplification is quite varied in metastatic colorectal cancer. It ranges between 2 to 4% in an unselected group. Now, if we want to select which patients to actually test for, if we look at patients who are KRAS, NRAS, BRAF, and PIK3CA wild-type tumors, it increases, the prevalence increases from 2 to 4% to 36.4%. So probably this is the group of patients that we should test for. What are the therapies that have been combined or tested in such a group? There was trastuzumab pertuzumab, trastuzumab lapatinib, trastuzumab tucatinib, and in later line setting, trastuzumab deruxtecan. And this was well embedded in the in last year's NCCN guidelines. As you can see, it gives 4 options for HER2 amplified metastatic colorectal cancer. Heracles tested lapatinib plus trastuzumab. Now, all of these are phase 2 clinical trials, and hence the primary endpoint that was reported was mainly objective response rate. And again, all of these trials look at patients who were heavily pretreated. So were given Oxali and irinotecan and progressed on both. So the objective response rate here for lapatinib and trastuzumab was 30%. In the TRIUMPH trial, there were 2 trials, pertuzumab and trastuzumab, and the objective response rate ranged in this phase 2 clinical trial between 28 to 30%. Now, if we look at tucatinib and trastuzumab, this was tested in this phase 2 clinical trial. Tucatinib was combined with trastuzumab in a group of patients that progressed on oxaliplatin and irinotecan plus minus anti-VEGF antibody. And if we look at the confirmed objective response rate, we see that it goes up to 38.1%. And the disease control rate, so including patients who achieved stable disease, went to a mere 60% in such groups. And as you can see on your right-hand side, the majority of subgroups benefited from this combination. So this is the waterfall plot. Many patients responded. The objective response rate confirmed was 38.1%. Median duration of response was actually 12.4 months, which is quite high in patients who are chemotherapy refractory group. And hence, this study led to an FDA approval for tucatinib and trastuzumab. So this is the only FDA-approved anti-HER2 agents in metastatic colorectal cancer. Now, this combination is being tested in the first-line setting in combination with FOLFOX, and this is going to be Mountaineer 03, which we are waiting for the results for. What about KRAS G12C? So this represents a small subgroup from our metastatic colorectal cancer cases. It's not very common. An Italian group went retrospectively and did a real-world study looking at the overall survival impact of KRAS G12C mutated patients. And they actually reported that these patients do significantly poorly with a median overall survival of 28.9 months compared to patients who are non-G12C mutant at 36.7 months. Now, KRAS G12C, again, is a small subset of all KRAS mutated patients, and the prevalence is about 3%. How did the story of KRAS G12C inhibitor start? It started with 2 agents, sotorasib and adagrasib, as single agents in CRYSTAL-1 and CodeBreak 100. The objective response rate was modest, with 10% for sotorasib and 22% for adagrasib. Now, these again were single agents in heavily pretreated group. When combined with monoclonal anti-EGFR EGFR monoclonal antibodies, so cetuximab with adagrasib and sotorasib with panitumumab, the objective response rate increased significantly. So in CRYSTAL-1, it reached 43%, and in CodeBreak 101, it reached 33.3%. This led to CodeBreak 300, which was a large phase 3 clinical trial, and which was presented in ESMO a couple of years ago in the big ESMO Congress. And again, panitumumab was added to higher dose sotorasib, so 960, which will focus on lower dose sotorasib and investigator choice, which is either regorafenib or TAS-102 in the third-line setting. Progression-free survival favored the addition of higher dose sotorasib, so 960 plus panitumumab, reaching a progression-free survival of 5.6 months. And remember, this is in a group that were heavily pretreated. Now, the median follow-up data was 7.8 months, so very short. The overall survival data was not mature at the data cutoff. And hence, the conclusion was that sotorasib 960 milligrams of the higher dose plus panitumumab should be a new standard of care for patients with chemorefractory KRAS G12C mutated colorectal cancer. Now, the last story would be the NTRK story. Should we test everyone? Is it cost effective? perhaps not. The prevalence of NTRK fusions in an unselected group of metastatic colorectal cancer is quite small. It is reported in some studies to be as low as 0.3%. However, in MSI high subgroup, the NTRK fusions go up to a prevalence of 7%. So probably this is the subgroup of patients that we should be testing for. Now, this is my last slide. I thank you all for listening.
Thank you, Dr. Shabari, for review and targeted therapy for the colon cancer. In the next 20 minutes or so, we'll move now to another cancer site in the GI, and this is in biliary cancer. Dr. Abdelhamid Faqih, he will enlighten us and discuss the precision in that cancer site. Dr. Abdelhamid Faqih is a GI consultant in King Fahd Medical City, Riyadh.
السلام عليكم ورحمة الله وبركاته. صباح الخير لكم جميعا. And I would like to thank the scientific organizing committee and thank you, Dr. Fahad, for the introduction. So I will talk about the role of personalized therapy in the biliary tract cancer. I think this is not my slide. Yeah, so there is 2 Al-Faqih just for disclosure. So there is difference, yeah. So 1 letter only difference. So. So I will talk about a personalized approach in biliary tract cancer. So as a start, all of us know that biliary tract cancer is one of the aggressive malignancies. I always compare it with the outcome of pancreatic cancer. And despite all the progress that we have in different cancer management, the prognosis of biliary tract cancer remain very poor, with estimated 5-year-old survival of less than 20%. Unfortunately, most of the patients at the time of diagnosis estimated to be around 80% of cholangiocarcinoma patients will be diagnosed with the advanced stage. And one of the publications by Dr. Kanaan reported study like mimicking our population, almost 33% of patients with biliary tract cancer, they were not fit enough to go for first-line therapy. Moreover, patients who received the first-line therapy, majority of them, they will not make it to go for second-line therapy. So this tells you that we need to apply personalized medicine, and I think biliary tract cancer is one of the areas that we can utilize personalized therapy option. In addition to that, biliary tract cancer, it goes by different anatomical location, and we know that each location might have different driver mutation, and some of them are targetable with novel therapies. If we look to the molecular profile of biliary tract cancer, this slide, probably there are 68 different molecular alterations, and unfortunately, not all of them we have targeted therapy for. But for example, we have some that we can target it with a few targeted therapies. For example, if we speak about gallbladder cancer, it has different molecular profile than intrahepatic or extrahepatic. For example, it has more HER2 or possibly KRAS. Extrahepatic also might have BRAF, KRAS. Intrahepatic, I think this can have more targeted options like FGFR fusion targeted therapies or IDH1 or 2 mutation. If we move on, there are multiple pathways that we can target, and the translational and preclinical research had made a lot of efforts to look into efficacy of different medication. Till now, we have successful targeted therapies effective of some of these that I will talk in the next few slides. But before that, if we go to what is the standard of care for management of biliary tract cancer, for decades, the cisplatin gemcitabine combination was established frontline therapy, and recently two immune checkpoint inhibitor, either durvalumab or pembrolizumab, added to the backbone of cisplatin gemcitabine, showed improvement in overall survival and progression-free survival, and hence they were established to be frontline therapy. So the management in the frontline setting still universal approach for all patients. And in the second line used to be only FOLFOX chemotherapy or regorafenib or maybe irinotecan. But this is the NCCN guidelines that the molecular testing, I think, should be done for all patients who had advanced biliary tract cancer. And if we don't have the extended panel for NGS, at least we should look for all of these mutation or alterations that we have targeted therapy for. And this include NTRK, MSI high, tumor mutational burden, BRAF, and FGFR fusion or rearrangement, IDH1 and HER2, RET, and KRAS G12C mutation. I will go through targeted therapies that target these alterations, starting with IDH1. And this is more common in the intrahepatic cholangiocarcinoma. It is estimated to be around 4% up to 40%. And we have number of targeted therapies that is available to target this, but in the setting of biliary tract cancer, we have only ifosidenib. There are enisadinib or furisadinib, but this is not tested in the setting of biliary tract cancer. This mutation also, it's not only unique to biliary tract cancer, it can be seen also in other cancers like glioma and sarcoma. The trial that evaluated ifosidenib is CLARI IDHY trial, and this is phase 3 trial that evaluated the role of ifosidenib after progression in cisplatin gemcitabine-based chemotherapy. And this is the first oral medication to be used, and the primary endpoint of the study included different endpoints, including progression-free survival, overall survival. And if we look to the progression-free survival, we can see there is a benefit with hazard ratio of 0.37, and also there is improvement in overall survival, although it is very modest compared to placebo, but we can see that this mutation can be targeted with this therapy. Moving on to another pathway, cell proliferation pathway, and the main point here is the FGFR fusion or alteration, and it is common in intrahepatic cholangiocarcinoma, estimated to be around 40%. This is almost not seen in intra or extrahepatic cholangiocarcinoma, and cases of gallbladder cancer, they might have FGFR fusion up to 3%. We have different number of targeted therapies for FGFR. This include bimigatinib, infigratinib, fitubatinib, and erdafitinib. I will go through these. Let us start by bimigatinib. This was evaluated in phase 2 trial, and this trial included patients who had advanced unresectable biliary tract cancer, those who have documented FGFR alteration and had progression on at least one line of chemotherapy. Of course, they have to have excellent performance status. If we look to the design of the study, they randomized patients to 3 cohorts. I will focus here mainly on cohort A. This includes patients who have FGFR fusion or rearrangement. In the cohort 2, they looked for patients who have FGFR genetic alteration other than fusion or rearrangement, and the cohort C, patients who had no FGFR genetic alteration. These patients were treated with oral bimigatinib, 13.5 milligram, 2 weeks on, 1 week off, and the primary endpoint was overall response rate. If we look to the response rate in the cohort A, which is the group of patients who had FGFR fusion or rearrangement, they achieved overall response of around 37%, while cohort B, cohort C, we can see that they have 0 response rate. So this indicates that targeting this alteration with pemigatinib is very effective. And also this translated to improvement in progression-free survival as well as overall survival, with median overall survival reaching up to 17 months, which is very excellent in setting of aggressive cancer like biliary tract cancer. The toxicity of this medication was probably or generally well tolerated. Some hyperphosphatemia reported, but it's not affecting the outcome of that treatment. Moving on to another FGFR targeted therapy, infigratinib, evaluated in phase 2 trial. And again, this trial included patients who have FGFR fusion or rearrangement, and patients were treated with outcome. The primary outcome of the study was overall response rate. And if we see the waterfall plot, that objective response rate reached around 23%. And there is median progression-free survival of 7 months. I don't have the overall survival, but based on this, this medication was also approved by FDA. Moving on, another FGFR targeted therapy, fotibatinib, and this trial included patients who had FGFR fusion arrangement, and it showed also improvement in response, progression-free survival, and median overall survival better than reported in other FGFR targeted therapies, reaching in this trial up to 22 months. Erdafitinib, I think this is more used in bladder cancer, but also it was tested in the this basket trial, and there is cohort of patients who had biliary tract cancer. And again, we see objective response reaching up to 60% with median overall survival reaching 18 months. So at the end, we have 4 medications. All of them are effective in targeting FGFR pathway. Moving on to another important pathway in the biliary tract cancer, which is BRAF. Although this is not quite common in the biliary tract cancer, but it can be seen in extrahepatic or gallbladder cancer, and also intrahepatic cholangiocarcinoma. It is ranging from 1 to 7% in best case scenario. We have very successful stories with targeting BRAF in different cancers, including melanoma, lung cancer, thyroid cancer. And we know that the targeting BRAF is linked to the pathway of MYC and ERK pathway, and some resistance might be found in this. So in order to overcome this, always it is better to combine BRAF with anti-MYC inhibitor. We have ROR phase 2 trial. This is basket ROR trial that included patients who were treated with dabrafenib plus trametinib, and also it included patients who had BRAF mutation, those who progressed on standard first-line therapy. And we can see that this trial showed improvement in progression-free survival and also response rate reaching up to 51%. The overall response, again, is reaching around 50%. And here is the overall survival, almost, and we are exceeding 12, 15 months. Moving on to another pathway, HER2 pathway, and this is more common in gallbladder cancer and extrahepatic cholangiocarcinoma. We have different medication, possibly similar to what is mentioned by Dr. Kanaan in colon cancer: trastuzumab, bertuzumab, trastuzumab, tucatinib plus trastuzumab, and TDXD, and finally zandatimab. So let us start by tucatinib plus trastuzumab. This was reported in phase 2 trial that included different cohort, and one of them is biliary tract cancer. And also here they looked specifically to the efficacy of this medication in IHC plus 3. So we can see that there is objective response as well as overall survival benefit possibly exceeding 12 months. And if we move on, trastuzumab plus pertuzumab were tested in another basket phase 2 trial, included different cohort of patients in biliary tract cancer. And we can see there is objective response as well as a progression-free survival. The objective response here reported to be around 23%. Moving on, trastuzumab deruxtecan. It's very effective in breast cancer, but unfortunately, it's not quite similar story in biliary tract cancer. Although this trial included patient tumor trial, different cohort of patients. And if we look to the biliary tract cancer, they included a patient who had IHC +3 or even less than that. But the benefit or the major benefit seen in patients who had only immunohistochemistry expression of HER2 +3, progression-free survival, and also overall survival exceeding possibly here 12 months. Zandatimab, another unique targeted therapy for HER2. It worked by binding to two different locations within HER2, and theoretically it showed more efficacy in targeting HER2, evaluated in phase 2 trial, and it showed objective response and progression-free survival benefit. What about combining chemotherapy with anti-HER2, for example, folfox-trastuzumab? Again, this was evaluated in Korean trial, and it showed overall response rate reaching up to 29% with disease control rate of 79%. Another combination with the chemotherapy, this is Gemcis plus trastuzumab, and again, it showed a medium progression-free survival of 7 months. Moving on beyond the HER2 to another pathway in biliary tract cancer, which is KRAS. Although this is not quite common in biliary tract cancer, we have the subset of KRAS G12C, and we have adagrasib evaluated in this trial, and it showed also improvement on response rate and progression-free survival. So to summarize, so if we look to the NCCN guidelines, the management beyond first line, we have to do the molecular testing, and based on that, we can go. We have number of approved medication, and this most of them, as I mentioned, there are rare mutations like RET and NTRK. These are very rare, but can be targeted with entrectinib, for example, for NTRK. ISMO guidelines still possibly not updated, but also it reflects that we should test for all of the available molecular alteration, and if we have any targetable alteration, we should target it. So I have to go to conclusion. So we have some significant progress in the second-line management of biliary tract cancer, and targeted therapies might offer extension of progression-free survival and overall survival for some patients. And identifying those targetable mutations is very essential for personalized medicine for biliary tract cancer. And with this, I conclude, and thank you so much.
Thank you, Dr. Hamid. Then I leave the questions at the end. We'll move to second lecture. Our next topic about evolution of precision oncology in another important sites of GI malignancies, gastric and esophageal malignancies. Our speaker, he's a senior consultant at yes, senior knowledge and contribution. He's going to present. He's a consultant at Faisal Specialist Hospital in Riyadh. Much is yours, Dr. Ali.
So good morning, everyone. Thank you for inviting me. This weekend is the best, meeting all of you. Al Hilal won, Nasr lost, Ittihad lost. nothing better than that. So it's exciting topic, evolving role of precision oncology in gastric and gastroesophageal cancer. And if you ask me, in all GI malignancies, you will find that gastric and gastroesophageal kind of the poster child for all the targeted therapy. Let's look at the prevalence in the beginning. So more than 1 million cases of gastric cancer are diagnosed. It's considered the 5th most prevalent cancer. And now look at, for example, in Europe, you will see that more than 160,000 cases diagnosed yearly. Unfortunately, most of these patients present as metastatic disease, and overall, they have a dismal prognosis with median survival of 9 to 11 months. So what we have so far is HER2, MSI high, and PD-L1 expression. These are the 3 that determine how we treat our patient in the frontline setting. However, welcome to the new kid on the block, Claudin 18.2. And this is an interesting topic that we're going to address later on in the slides, but also it opens treatment options for our patients. Not only that, I bet that if FGFR2b is coming, and maybe it will need a few years to see this coming, inshallah. So what we have in the clinic are based on validated phase 3 clinical trials, which are HER2, targeted therapy, targeting PD-L1, and the Claudin 18.2. Now, we kind of extrapolating evidence based on phase 2 and phase 3 subgroup for those MSI high, tumor mutation burden high, and EBV positive. And the promising phase 2 trials are showing that there are signals for FGFR2, MET, EGFR amplification, ALK-fusion, and BEC3 cancer mutation. So if you look at the prevalence, for example, let's start with HER2 positive. Depends on where you're looking, you will see that it's ranging between 14 to 22%. Now, CBS in general, more of the patients are CBS positive, neither to be negative, but most of them are CBS 1 and above. Now, for Claudin 18.2, we're talking about more than a third of the patient, they will be positive for Claudin 18.2. What I'm also excited about in the future, inshallah, we'll have FGFR2b positive, which is counting for 30%. Hopefully, another option for our patient in the future. Now, let's, for example, look at Claudin 18.2. You see that the CBS 1 and above is counting 25% of those populations. CBS above 5, 17.9. HER2 is kind of overlapping around 15%, and MSI high is around 12.8. So that's kind of going to confuse us in how we can treat patients. So maybe this is for the discussion later on. But first-line treatment recommendation for gastric and gastroesophageal cancer becoming more and more evolving and rapidly evolving. Look, 2010 started with trastuzumab plus chemotherapy, but then it took us 11 years just to figure out there is something that we can use, which is immunotherapy. And since it started, we had a lot of IO therapy options, including nivolumab, pembrolizumab, combining pembrolizumab with HER2, and lately, Claudin, which is 18.2 inhibitors like zolbetuximab, and most recently, another IO therapy like tislelizumab, which is EMA approved, but not FDA approved. Now, the ESMO Living Guideline, the one from September 2024, you will see that we have so many options, and the way how we navigate this is basically molecular. You look at the CPS, HER2, but to begin with, you look HER2 negative or positive. If it's negative, then you go to the CPS. If CPS positive, then you have the IO therapy option. Now, Claudin 18.2, if it's positive, then you have another option, which is zolbetuximab. Those with the negative CPS and the Claudin 18.2, you have the option of chemotherapy or even intensifying chemotherapy. Now, MSI high, usually you just add immunotherapy and we're going to touch base on it. So let's take it one by one. This is for the CBS 1 and above where you add immunotherapy. So PD-L1 expression tend to be more in proximal gastric cancer and classifiable, papillary, tend to be also HER2 positive, MSI high, and BEC3 cancer mutant. So these are the two most important clinical trials that influencing what we practice, which is the Checkmate 649 and Keynote 859. And you see the Pembro for CBS 1 and above, you see the survival benefit, and nivolumab addition in the Checkmate 649 for those with CBS above 5. So quickly we'll go over the Checkmate 649, where chemotherapy plus nivolumab versus chemotherapy, primary endpoint was OS and PFS for those who did not receive prior treatment. Majority of the patients were CBS positive in this clinical trial. You see that in the overall survival, specifically for CBS above 5, the delta is 3.3 months, and the hazard ratio is 0.70. Now, in the efficacy subgroup analysis of CBS, really who derive benefits is those with CBS 5 and above. And you can find that 1 to 4, they really did not derive much benefit. Now, for the Keynote 859, they compared pembrolizumab plus chemo versus chemotherapy alone in the same patient population. Primary endpoint this time is not co-primary endpoint, but just OS. And this time the delta is 1.4 months, and the hazard ratio is 0.78. Now, in the subgroup analysis, definitely, although it's different than the way they did it with the nivolumab, here they kind of categorize it differently, 1 to 9, and less than 1, and above than 10. Clear benefit for those above 10. Now, 1 to 9, you don't know really. Is it 1 to 5 or 5 to 9? So I wonder what's going to be the result if it's stratified the way it was stratified in the patient who got nivolumab. So targeting PD-L1 inhibitor does not only nivo or pembrolizumab. We have another comers, rationale 305, adding tislelizumab to chemotherapy. And you see for those with TAB score above 5, you can see a survival benefit. Median overall survival is 17.2 months versus 12.6. Similarly, we can see some survival benefit on those in Orient trial given sunitinib. Now, the problem is the tissue, and the tissue always the issue, because most of the time we get the diagnosis, it's adenocarcinoma, but we don't have enough tissue to diagnose or to do molecular testing. So our standard, for example, the hospital that I'm working at is at least 6 endoscopic biopsy specimen should be obtained. Not only because of molecular testing is needed, but in gastric cancer, it's very heterogeneous disease. Not only in PD-L1 expression, but also in HER2 positive and MSI high. You might be missing patients by not having enough tissue for the pathologist to diagnose. Now, PD-L1 scoring system is not that easy, and you will see different scoring system, either TAB, CPS, and all of that. Cell counting, whenever there is counting, there is error. And visual estimation, to me, and I'll show you later on, probably a better way to do it. And that's why you will see more and more TAB score in the future. Now, the discordance between biopsy and resection specimen. And this is well known. And you can see that if you get a biopsy and you get a surgical specimen, you are dealing with a bigger tumor, so probably, or bigger tissue, so you probably will have more to diagnose with. For example, here in this study, you will see that accordance rate is 64%. What does that mean? We are missing more than 30% on the biopsy side. So how we can overcome that? What I mentioned earlier, having more biopsies. And you can see here that the number of biopsy can make the accordance rate much higher. So PD-L1 staining, I always, when I see a calculator, I know there is a problem. As a medical oncologist, I don't deal with calculators a lot. I like Fahad. Fahad, you're good in maths, huh? So look at this, for example. It's CBS here. You basically combine, you look at the immune cells, tumor cells, you divide it by the total number of cells. So it depends on the tissue that the hotspot that the patient is looking at. So it is imperfect testing. CBS is not the best. And I'll tell you why. Because there is the human part, the inter-observership variation. And this time, the issue is not the tissue. And I'll show you, this is a major study that was done in a clinic, and they included multiple centers. They trained 12 pathologists, and they tell them, this is a 100 case. and we will train you to do all of you the same, to look at the CPS. And after that, we'll give you a break for 2 weeks as a washout period. And then we'll make you test CPS and look at the variation. So you can see the variation is kind of different. And mainly the variation gets noticed in those with CPS 1 to 10. Above 10, it's clear for most of the pathologists. So I'm not going to go into the details. However, tumor area positivity score is basically the average. They looked in this study to the average positive agreement and average negative agreement. And it's just visual estimation, so it was better. And in this situation, for TAB score of 5 and above, the concordance rate was high between pathologists. So are PD-L1 assays in gastroesophageal cancer, are they interchangeable? Fahad disagree with me all the time, but to me, they are. Now, this is the PD-L1 concordance between different assays, a big study that with Precision Oncology, GCO, and they found that it's kind of interchangeable. And I'm saying that because most of us, we have different kits, availability is important, so you can rely on whatever you have. That's my opinion. Now, this contradicted by a study in ASCO GI 2022, where they found that no, some assays can overread CPS. And here, for example, assay 288, the CPS above 1 was much higher compared to SP142 or 22C3. However, I did not find a complete publication for this abstract that was presented. So bottom line, whenever it's CPS 5 and above, I ought to go for 1 to 4. It's debatable. How should we do for it? And for those with CPS negative, it definitely no IO recommended. Now HER2. HER2 basically more commonly seen in intestinal type, proximal tumors, and overexpression. Many of us think it's really aggressive tumor. However, there is no data to tell us more, especially with the anti-HER2 now. Probably we have a better survival for those patients. So in general, whenever you have HER2 positive plus 3, you look at CPS positive, you add IO plus trastuzumab and chemo. If it is negative, then you go back to 2010 and use TOGA trial, which is trastuzumab plus chemotherapy. Now, TOGA showed that adding trastuzumab to chemotherapy did improve survival with delta of 5 months. Now, the most important trial was the Keynote 811 in 2022, which showed that addition of pembrolizumab did improve survival, and this time we're reaching 20 months median overall survival compared to 15 months. This is the trial, basically looked at pembro plus trastuzumab plus chemo, or trastuzumab plus chemo plus placebo, and dual endpoint of OS and PFS. Now, for those with CPS negative, did not really derive any benefit. And even you see the follow-up data really did not show any benefit from adding pembrolizumab. So HER2, in general, it's important to know that we only treat, unlike breast cancer, it's IHC3 plus, those are population we treat. But it's important study here, and I like it a lot. It's variance study where they looked at the staining of HER2. And you can see here, both of them are HER2 positive, but you can see it's widely expressed everywhere on the right. And in the left, it's very intense on the lateral side. So all of them considered positive, but it's heterogeneous. So it depends on the tissue that the pathologist looks at. In the same study, they tested local and central HER2 testing. And you find that those who have centrally positive HER2 and locally positive HER2 derive the most benefit. So sometimes we might be labeling patients they are HER2 negative and they are not. Who knows? Now, in the HER2 variance study, they looked at the cell staining, and they said to be comfortable, 40% staining is the cutoff where you can see that really patient derived benefit from adding trastuzumab. The same thing, the cutoff for the amplification ratio was 3. Now, if you remember the HER2 cell staining, we are talking about 10%. That's the way how we call HER2 positive. In unlike colon cancer, it's 50%, gastric cancer is just 10%. Now, trastuzumab deruxtecan, most of you know what is the mechanism of action, but it started with Destiny Gastric 01, heavily pretreated patient. They compared TDXT at 6.4 milligram per kg compared with chemotherapy, whatever the physician choice. Objective response rate was magnificent. We're talking about 43% versus 12, and overall survival 12 months versus 8 months. Now, moving to Destiny Gastric 02, this is mainly second line, and they use the same dosing, 6.4 milligram per kg, and the primary endpoint was objective response rate. Objective response rate was 38%, and the disease duration of response was 8.1 months, and the PFS is 5.5 months. Moving to the most recent one, Destiny Gastric 03. Basically, it worked in the second line. Let's give it a try in the first line, but let's have different combination. But this time they used also 6.4 milligram dosing and 5.4 milligram dosing. And you can see that the objective response was seen across most of them. However, the interest was mainly for those with TDXT 5.4 milligram per kg because there was no big difference than 6.4 with probably less toxicity. As seen in the trial. Now, the 5.4 dosing is not mature yet, so the data is to come. So from this clinical trial, just give us a hint that the combination with 5-FU or KEPA plus pembrolizumab might be an option. So let's see when the data became more mature. But I bet this drug is coming. As what we saw when Dr. Abdelhamid mentioned zanidatamab in the HER2 positive BTC, it did work. So, and in gastric cancer, it's been testing. It has a unique mechanism of action working in two domains, single chain variable fragment in the heavy chain 1, as well as on the fragmented chain antigen binding domain in heavy chain 2. And the preliminary data from the Horizon GAA, you can see that those who got zanidatamab plus chemo has impressive response rate. Additionally, zanidatamab plus chemo plus immunotherapy also had an interesting objective response rate. Small number of patients. So what we wanted to see, hopefully in a year or so, we will see the data coming from group 2 and group 3, which is zanidatamab plus chemo and zanidatamab tislelizumab plus chemo in the frontline setting. Now, MSI high is, I would say that it's much less than that. It's 3 to 7% in general. And in general, you just add immunotherapy to chemotherapy. That's the bottom line. But where is that came from? Basically, Keynote 062, 3 arms, chemo IO alone, which is pembrolizumab, and chemotherapy. You see there was no difference between the chemo plus IO versus IO only or chemotherapy or pembrolizumab alone or the combination pembrolizumab plus chemo. But if you dig deep into this study, you'll find that the objective response rate was much higher with combination of chemo and IO. But also you can extrapolate things from Checkmate 649, Ipi-Nivo. There was an arm of Ipi-Nivo, and you can see that here the median overall survival is 38.7 months in 23 patients with MSI high. Now, also the pembrolizumab clinical trial, you can see in the subgroup analysis, the 39 patients, a clear benefit from giving IO with chemotherapy. Now, emerging biomarkers, Claudin 18.2, and this is of interest, and hopefully we can see it in the clinic for a good number of patients, inshallah. So 33 to 38% of patients, they have Claudin 18.2. Tend to be younger age, female sex, diffuse type disease, and Claudin 18.2, regardless of where they come from in terms of population, because the thought process in the beginning thought to be it's more in Asian population, but it's not true. You can see it across all population. Now, in the spotlight, we're talking about 38. Similarly, in the GLOW trial, for the bezaclarides zolbetuximab. So it can be found regardless of the histology, not specifically intestinal type or diffuse type. Claudin 18.2 has an interesting mechanism of action, has an EDCC and CDC kind of mechanism of action. It is basically binding to the tight junction and epithelial sheath that's usually not expressed in normal tissue. So unlike EGFR, for example, this you don't see it unless there is a tumor. So started with FAST, phase 2 study, they looked at zolbetuximab because people say where the 70% cutoff of diagnosis came from. So FAST is a phase 2 study, looked at zolbetuximab as a monotherapy, and they found that zolbetuximab with EOX versus EOX alone, you can see that those with expression of 70% or more derive benefit. Those less than 70%, there was no difference compared to chemotherapy. Now we see it in the guidelines that you can give zolbetuximab in the ESMO guidelines to add it to the chemotherapy in Claudin positive. But where did this came from? Came from GLOW study, which is basically looked at CAPOX plus zolbetuximab, and here we are talking about median overall survival of 14 months versus 12 months in the chemo arm. And the spotlight, and this time is 18 months versus 15 months. And then we had this combined analysis looking at both of these trials and see that clearly there is survival benefit of 16.4 versus 13.7 with hazard ratio of 0.77. Now, toxicity, because most of us did not try it in the clinic, but mainly nausea, vomiting kind of situation, rather than weird side effect that you might think that we will find it with zolbetuximab. So it's FDA approved in October 2024, but the story of Claudin 18.2 did not end yet. So we will have anti-drug conjugates, hopefully with encouraging data, who knows? But also there are so many ongoing clinical trials looking at CAR-T for Claudin 18.2 since it's widely expressed and it is homogeneous disease, unlike HER2 and CBS. So emerging biomarkers, the FGFR2, and this is basically seen in the FIGHTER trial that looked at adding chemotherapy to bemarituzumab, which is FGFR2, and you can see that the median overall survival is quite impressive, 19.2 months versus 13.5 months. Ongoing phase 3 clinical trial is on the road. So again, what we have is HER2, CBS, Claudin, but we have promising phase 2 clinical trials, and including targeting ALK fusions, EGFR amplification with cetuximab, for example, FGFR2, and etc. Thank you for listening to me, and I apologize for that.
Thank you very much, Ali, for the nice presentation. So it's my pleasure to present the last speaker, Dr. Abdullah Sherm. He's one of the new consultants here. Since Ali is a senior oncologist, Abdullah is one of the best junior that I've teach.
Yeah, I am the younger junior today.
Exactly. I teach you myself, Abdullah. And he's one of the best oncologists. Honestly, no one on earth doesn't like Abdullah Sherm. Everybody loves Abdullah. So Abdullah will talk about my favorite topic, about HCC and how to choose the first line. Are you better than me?
No, definitely no. Assalamu alaikum jami'an. To start with, I would like to thank you, Ashwaq. Thank you, Dr. Kanaan. Thank you, Dr. Mohammed Al-Garni, for inviting me today. And it's always my pleasure to be one of the faculty in this meeting. So usually we start with dumping a lot of information, but let me start with asking you a question. This is a patient that I saw in my clinic, 65 years old, with child A hepatocellular carcinoma, with history of hematemesis. Upper GI endoscopy showed grade 2 esophageal pharesis. What's the most appropriate therapy? Single agent lenvatinib, single agent nivolumab, trimi, dorva, or atezo-beva? What do you think? So let's vote very quickly. Single agent lenva, Shwag, Kanaan, single agent nivolumab. Okay. Stride protocol. Okay. All of the stride, atezo-beva. Okay, fair enough. So when we look for the hepatocellular carcinoma, it's number 10 among Saudi patients, and it's if you see for both genders. And then for the male, it's almost number 7, and for the female, it's again number 10. One of the most difficult type of disease that you treat is hepatocellular carcinoma. Basically, we are not dealing with one disease. It's hepatocellular carcinoma plus sick liver, or what's called liver cirrhosis. Definitely, we have a sick patient, limited access, too many players, and definitely lack of clear standard of care. And the management of hepatocellular carcinoma, it's not anymore one-man show. It's a multidisciplinary hepatology, radiology, surgery, oncology, interventional radiology, pathology, and palliative care. All of them should be set on one table to discuss the patient. And as you can see, there is a lot of retrospective analysis showed that multidisciplinary approach with the patient with hepatocellular carcinoma associated with clear improve in early detection and definitely the survival. Now, we know that clearly the progress in HCCL in cirrhotic liver, and definitely, as you can see, the timeline, there is a tremendous change starting from immunotherapy 2017. Subsequently, we have a cascade of clinical trial showed clear improvement in overall survival in hepatocellular carcinoma. Now, there is at the meantime 6 important clinical trials. As you can see, the first 3, it's USA, and the last 3, Orient case and Apollo trial, it is a Chinese, while we are in the big trade between the China and the USA. I think we need to discuss the USA as our benefit. It's more with the USA. So, let me go with the 3 important trials. The first one, no, I think we are in the right. We can go back. Okay. So as we said, there is a 6 important clinical trial, phase 3 clinical trial, 3 of them USA and the 3 China clinical trials. And definitely we are going to discuss the 3 important clinical practice changing in our clinical practice, which is EMBRAVE 150 Himalaya trial and the Checkmate 9DW. And very quickly to discuss about the clinical trial, the EMBRAVE clinical trial, a very important phase 3 clinical trial, examining atezolizumab plus bevacizumab versus sorafenib in patient with child 8. They randomized to atezo-beva versus sorafenib, and the primary endpoint was overall survival as well as progression-free survival. And as you can see in the latest 5 years update analysis, you can see almost improvement of 6 months from sorafenib to atezo-beva. Very significant hazard ratio in the updated analysis of 66 and the p-value of 0.009. This again was reflected in progression-free survival as well as and confirmed overall response rate of almost 30% compared to 11% in hepatic carcinoma. And definitely when we speak about the side effect, mainly with atezo-beva was related to the beva, high blood pressure, proteinuria, compared to the sorafenib, which is usually hand-foot syndrome and GI toxicity. Very important to keep in our mind when we have an overall survival, we would like to look for the quality of life, and clearly both combination therapy delayed deterioration of patient reported decrease in quality of life. The second important trial, which is the Himalaya trial, which is again phase 3 clinical trial. It was started with a 4-arm, then the arm of tremi of 75 for 4 doses was shut down, and the DORFA versus the STRIDE protocol versus the sorafenib, and the overall survival was the primary end point. And as you can see, the overall survival in the updated analysis, you can see very clearly, and almost 3-month improvement in overall survival with a hazard ratio of 0.76 and the p-value of 0.0008. And definitely the most side effect with the STRIDE protocol was immunotherapy related. And as you can see, in grade 3 to 4 was almost 10% of the patient on the STRIDE protocol. Again, very important data about the quality of life was well preserved with the STRIDE regime. The third important trial, the Checkmate 9DW, which is a Nivo plus AB of 3 milligrams. We all the times, we know that we give ipilimumab as dose of 1 milligram. In this trial, they give it as dose of 3 milligrams for 4 induction, then nivolumab of 480, compared to the very important, old previous trial was comparing to sorafenib. Here they were comparing to lenvatinib and sorafenib. And again, if you see the overall survival, you can see we are reaching almost 23.7 months. But look to the control arm, it is almost 20 months. It's unheard of with sorafenib plus lenvatinib of reaching 20 months. LB value was very significant and hazard ratio 0.79. And the treatment side effect mainly was with a double immunotherapy, as you know it for, most of us was with high blood pressures, patient with hypothyroidism, endocrinopathy. And again, when we look for this trial, it's again showed, very important delay in first symptoms duration and quality of life. So 3 important clinical trials. Let's go and look for the trial head-to-head. So we look for these 3 clinical trial was compared for patients with child A only. They did not include child B. And if you look for the arm in the child A, IMbrave 150, atezo-bevo versus sorafenib, Himalaya Stride versus durvalumab versus sorafenib, Checkmate, Nivo plus AB versus lenvatinib or sorafenib. And as you can see, the viral etiology, you can see in IMbrave is almost 50% with hepatitis B, 21 hepatitis C, and 30% of non-viral, which is again almost 40% in Himalaya of the non-viral and almost 37 in the Checkmate. Microvascular invasion was 38 and 26 and 23. You can see the highest one with IMbrave 150. Extrahepatic metastasis was almost 63, 53, and 56. High alpha-fetoprotein was almost 30% of all the clinical trials. And as you can see, the survival benefit, I would like to concentrate on the hazard ratio. Look to the hazard ratio, the update analysis of IMbrave 150, it's almost 66, the most pronounced one, compared to the hazard ratio of the Himalaya of 0.78 and 79 with the Checkmate 9W. And again, if you look for the progression-free survival, again, you can see very significant hazard ratio of 0.65 compared to 0.90 hazard ratio with the Stride and 0.87 with the Checkmate clinical trial. And if you look for the response rate, was almost 30% with IMbrave, as 20% in Himalaya, and again was almost 40% with the Checkmate 9W. And if you look for the disease control, was 74, 61 in Himalaya, and 68 with the Checkmate. And if you look for the complete pathological response, radiological response was 8% in the IMbrave trial, with 3% in Himalaya and 7% in the Checkmate clinical trial. This is the most important slide because if you look for the side effect, the grade 3 to 4 side effect toxicity from the IMbrave, it's almost 40%. With IMbrave 150, in Himalaya is almost 25, and then Checkmate, it's again 40%. The steroid use, again, if you look for the IMbrave, it's almost 10% compared to 20 with Himalaya, raised to 30% with the Checkmate. And if you look for the rate of discontinuation, was almost 22. The highest was with IMbrave 150, 13% with Himalaya, and 18% with the Checkmate. The rate of treatment death-related is 2% with IMbrave, 2% with Himalaya, and almost doubled 4% in the Checkmate. And very important, look for the bleeding rate, 6.4 compared to 0.5, and we don't have any report yet from the Checkmate 9DW. So can we individualize our approach? So let me go back and look to this question that I asked initially. 65, old, with a child A hepatocellular carcinoma with history of hematemesis, upper GI endoscopy showed grade 2 esophageal varices. What's the most appropriate therapy? Now, if you look for the exclusion criteria of the IMbrave 150, actually they exclude those patients. Those who has hematemesis and it's uncontrolled or uncompletely treated, they were excluded totally from the clinical trial. However, they did include the patient with vascular invasion of the portal vein and hepatic vein. Let's go with the answer of Dr. Ashwag, which is the Himalaya, she's a Stride protocol. They exclude this patient from the clinical trial. And as you can see, active or prior documented GI pharyngeal bleeding or history of upper GI bleeding ulcers or esophageal varices with the bleeding within 12 months, all of them, they were excluded from the trial. And also, very important to keep in our mind, those who has a main portal vein thrombosis, they were excluded from this clinical trial. So the Himalaya, it's not applicable for these patients. So what about the etiology? Now we know that there is a viral and non-viral, and we know that the non-viral, one of them, it's, what's called it? Lynch syndrome, not Lynch, NASH, sorry, NASH. And all the time we have a difficulty with the NASH, how to diagnose NASH. The ideal diagnostic test is doing the biopsy, and unfortunately we are not doing. So we're assuming that those who has a viral B, not non-viral B or C, they are a NASH. And if you can see in the EMBRAVE, when they look for the subgroup analysis, the benefit for the non-viral was almost zero. It's 1, as you can see, the cross line very clearly, and the hazard ratio of 1.05. Now, what about the etiology in the STRIDE protocol? The STRIDE protocol, if you look for the hepatitis B, they have benefits. Hepatitis C, 94, and those who has an non-viral 75. So those who has hepatitis C, shall we exclude them from the trial? And this is the area of discussion later on. And if you look for the CheckMate, the trial, if you can see the benefit was actually with hepatitis C. Remember, this trial was hepatitis C, they don't respond, while here they very well respond. And as you can see, it's very remarkable, 0.68. Shall we adapt this in our clinical practice? I think no, this is subgroup analysis, but it's very important to keep in our minds. Dr. Ali was complaining about the calculation, and he's very bad in calculation like me, but I do believe the combined positive score better than the ALBI score. If you'd like to calculate log 10 bilirubin multiplied by 0.66, albumin multiplied by minus 0.85, and if you look for the EMBRAVE, they actually calculated, and those who has ALBI grade 1, they benefit very remarkably compared to the ALBI grade 2. And if you look for the STRIDE, when they look for the ALBI, regardless of the ALBI 1 or 2, actually they benefit. Shall we adapt this? It's again, it's subgroup analysis, but we need to keep it in our mind. And if you have calculation in your clinic. So not all the immunotherapy or immunotherapy combination was a really success in hepatocellular carcinoma. This is a very important two clinical trial, lymphatinib plus pembrolizumab versus lymphatinib. So I think the problem with this trial, they are choosing lymphatinib as the control arm, and ideally it should be sorafenib to get any benefit. And in this trial, it was completely negative trials. Another important phase 3 trial, Cosmic 312, Cabo plus atezo versus sorafenib versus Cabo. Again, it was completely negative trials. So there is a many factor actually need to be considered in treatment decisions, patient factor, treatment goal, treatment factor, and definitely the risk factor. And all the time, remember that we have two diseases, liver cirrhosis with all complications and the hepatocellular carcinoma. There's a very important meta-analysis from Dr. Saif Dehan. It's very clearly those who has cases discusses in multidisciplinary approach based on huge meta-analysis of 12 study, 15,000 patients. It showed remarkable improvement in overall survival for those cases was discussed in the multidisciplinary approach, reaching to almost hazard ratio 0.63. So the take-home message, hepatocellular carcinoma is rapidly evolving, and there is a lot of clinical trial going on at the meantime. Monotherapy with single agent, sorafenib or lymphatinib, it should be discouraged. And only if there is a clear contraindication to the combined therapy, because basically we are still seeing some patients, they are fit for treatment and they still receive sorafenib or lymphatinib in the first line setting. At the meantime, 3 approved regimen in the first line setting with child A, again, child A, because we are seeing some of our physicians, they cross child A and they give for child B, early B, some treatment with a combination therapy, atezo-beva, STRIDE or nivolumab plus abili. And finally, still clearly lacking the implication of introduction of IO in early setting. And we do know about the implication of this introducing of those medication early setting, especially in the adjuvant and with the TACE. And definitely we are still till today at 11 o'clock, we are lacking the biomarker to guide our therapy. And definitely the big concern, actually, we don't know what's the best sequencing therapy as subsequent line of treatment. With this, I would like to conclude. Thank you so much.
Thank you so much, Dr. Shurm. It's really great session. We start today in the morning covering upper and lower GI. So all the speaker, if you can come to the podium. I have a lot of burning question, and I want to use and abuse the gathering today to to gain a benefit. So I will start with the first speaker, Dr. Faqih. Dr. Faqih, you mentioned about Ali, the colorectal cancer, IO, and the colorectal cancer. So one of the debates between me and Dr. Gahtani in the clinic is to use double IO or single IO and the preference. Do you think now for all comer using double IO or single IO, assuming that you have a good patient, good performance? So which one is your preference and why?
Thank you. This is a really, difficult question to answer, but I think the two options are valid. So the decision whether to give combination or monotherapy depends on many factors, patient factors, preference, as you mentioned, performance status, comorbidities, and the most important thing is also patient acceptance and also the fitness.
So Ali, assuming you have 50 years, ECOG 1, 0, excellent shape, which one is your prefer, this or that?
We still have other factors related to the tumors, whether you have high burden disease, small volume disease, surgical decisions. So many factors, but for those patients who are minimally symptomatic, low burden disease, I would go for monotherapy. If the patient has high burden disease, very symptomatic, I think maybe combination would be a better option here. The other question, whether you can give chemotherapy initially, then switch to immunotherapy for those patients with high burden, very symptomatic disease. That's another question to ask as well.
Sure. Dr. Shur?
So Fahad, let me ask you and the audience, do we have the response rate of the Nivo dual immunotherapy, Nivo-AB? So I think if we have a high burden disease, as Dr. clearly mentioned, and the patient very symptomatic, I think I will go with the Nivo-AB. If the patient going for surgical resections, and there is a conversion therapy, definitely I will go with dual immunotherapy. Those who are asymptomatic, multiple lungs, small number, and they are not resectable, why I would bother him with the Nivo-AB? It's a very toxic, regimen. We need to keep in our mind.
But on the other hand, those patients who's having high volume disease, symptomatic, the question is, they will tolerate the double IO or no? Nivo-AB. So yeah, this is the dilemma that you will face.
It's better than, believe me, the chemotherapy plus target therapy.
Okay.
Yeah, believe me.
Okay. So the second question also to you, Dr. Faqih, about the change. Because one of the items that mentioned by Dr. Gahtani in the GE session, stomach, the concordance. One of my patients, he went to my clinic in 2019. MSI was stable. He's metastatic, by the way, since 2019 till today. And again, he went to my clinic, another biopsy, last year, 2024, and MSI is high. We're talking about the same patient, the same lab. 2019, MSI stable. 2024, MSI high. And by the way, I'm believing about MSI high because I started him in immunotherapy now for almost 1 year and you're doing very well. So do we have this kind of conversion, or I don't know what you called it, or lab error, or what?
I'm not sure about conversion from MSS to MSI high. There are cases, sporadic cases, they might have MSI high, but the germline MSI high, they don't usually convert. Once they're MSI high, they will be MSI high. But I think the problem is the testing itself, probably, yes. The type of the testing, whether immunostain, PCR, or NGS. Different assays has different results. In the CheckMate 8DW, there are 12% of the patients who are, when centrally reviewed, they were actually MSS stable.
Okay.
So we still have these patients. You should compare them with the better assay.
Thank you, Fahad. If you look for the initial trial of the keynote of pembrolizumab, there was 30% of the patient, they did not respond to the immunotherapy.
Yes.
70 respond, 30. And when they analyze this 30%, what's the reason for why they are not? They found almost 12% of those patients, they were actually not MSI high. They were actually MS stable, and despite of this, so lab error, no, it's not lab error, I would say it, I don't know how to, maybe testing method, yeah, testing method, I think it's play a major role in this.
Okay, so in the same concept, I want to ask Dr. Gahtani, testing method, pathologists changing their reports, as you mentioned, one of the trial that, so is there is a rule, although it's slightly deviated from your talk, is there is a rule nowadays about artificial intelligence in the testing of the BDL or the CBS or whatever score that we are using? Do we have any ongoing or presented data supporting using this as it's less error than the human error?
والله ما أعرف إلا ChatGPT. I'm not aware about any data about using artificial intelligence for testing. I know for sure that we have a problem like looking at, MSS or MSI testing. As you know, in many hospitals, you see that there was a mistakes that labeling a patient MSS or patients truly MSI. So I think to overcome this, for example, at our hospital, we are doing 2 pathologists MSI testing. So, and if there is discordance between these 2 pathologists, then a 3rd pathologist to confirm. So this is the, yes, INC, because mistakes can happen, and this is a disease that is, if there is MSI high, they respond to treatment. I wanted to go back to the idea of IO as a dual agent versus IO as a single agent in colon cancer. So the way how I think about it, and I'm a pro of dual IO, in colon cancer, if you look in the dosing is 1 milligram per kg. It's not a bigger dose. And on top of that, if you look at the toxicity profile that you see in the clinical trial, it wasn't that, a problem. I do have patient with MSI high gastric cancer, it's small hot tumor, and they got Ipi/Nivo when they did just well, and they are above 7 years old. Second thing is, you remember that the PFS with pembrolizumab is not the best. So the way how I think about it is I have 1 shot to give IO for my patient. And to me, is giving dual IO from the get-go for a better PFS, knowing that my patient has this chance. Let's say that patient progressed in pembro. What is your next step?
Chemo.
So, and with this PFS, almost 50% of the patient progressed. I will not risk it. I will give it.
We will stay with you, Dr. Gahtani. I believe you have one of your patients, rectal cancer, MSI high, and if not mistaken, you are the one here use dostarlimab. Maybe other also use it.
Me and Kanaan.
Okay. So how is your experience, you and Dr. Kanaan, about dostarlimab in those patients?
I had a patient with T4N2 disease. She had like a stoma, and she came to the clinic. They did not know that she's MSI high. Looking at the pathology before starting concurrent chemoradiation, found to be MSI high. The company, thankfully, they provided us with dostarlimab. Literally with dose 1, I saw her like 3 weeks after, and bleeding is gone, pain improved, and she's not taking painkillers anymore. And after 9 doses, she is in complete response endoscopically and by imaging. Yes.
What about you, Dr. Kanaan?
46.
So my experience is different with dostarlimab. I had a 38-year-old military guy who came to me from Taif. Unfortunately, mid-low rectal cancer, نفس Ali, T4N2. I actually gave chemo, waiting for dostarlimab. Then dostarlimab came, 8 or 9 cycles given, excellent partial response. I can feel still residual disease. So I actually discussed him with our radiation team, and he is currently receiving concurrent chemoradiotherapy. And the problem is he going to get an APR, or is he going to get a complete clinical response? And his social situation, military guy living in a Taif, is he going to come for close follow-up? That's another challenge. So most likely, I'm going to re-image him after a couple of months after concurrent chemoradio. And if he does not get a full response or residual disease, he's going to go for surgery.
Fair enough. Two different experience with the same medication, and this is what usually we see. And my question is to Dr. Al-Faqih, and this time with the benign or good Dr. Al-Faqih, not the malignant one. So, Dr. Abdul Hamid, you mentioned one of the local studies that conducted by Dr. Al-Shammari is that 30% of our biliary cancer, they will not be fit for the first line. So is it a message now to us as a practice oncologist, don't do this test for the second line? Or what's the ideal when I will request the NGS for preparing my patient for the second line? What I'm doing in my practice is from day one, if the patient is fit for the first line, I will go ahead. So what do you think? Is this wrong, or this is wasting resources, or what?
Thank you. I agree with you. This is a very aggressive disease. And I think at the early time of diagnosis, I would really sit for all of the molecular alterations that can be targeted in biliary tract cancer. Because if I wait, it might patient progress on the chemotherapy, and then I lose the window to start the treatment. So as soon as I get the diagnosis of this, I would like to send the molecular alteration, and possibly if there is any, which is, I'm not sure, like of my colleagues, I can comment on this. I have many patients and I sent all of them for the NGS, but I didn't really till now find any patient with actionable alteration.
Fair enough. One of my last question, then we'll go to Dr. Ashwaq to see the classic fight between US and China, Dr. Shurm and Dr. Ashwaq. My question to you, Dr. Shurm, just brief, like on Thursday, we met in our GI section in King Faisal to choose for the second alternative option in the first line for HCC. Regardless of the vote and regardless of the discussion, which one? Like you are stakeholder in your hospital, you want to choose another alternative other than anti-VEGF, because you have a big portion of our patients with esophageal varices not control. So you want to use double IO or stride regimen. You have to choose one of them. So to cover most patients with the HCC coming to your hospital. So which one is your preference?
Yes, thank you so much. So Kanaan, it just get the approval, I mean, last week or 2 weeks ago, I mean, new EP, just get the approval 2 weeks ago. We don't have yet the publication. We need to look for the publication of the clinical trial and to examine each point. It's very important. I mean, when I reviewed the data from Himalaya, I was looking for the exclusion criteria. They did exclude those who has upper GI and those with hematosis. In spite of, in our daily practice, any patient with esophageal varices, directly we go with the slide protocol. And they were excluded from the clinical trial. Some patients with a portal vein thrombosis, we exclude them from atesio beta. Why actually they were excluded again from the same trial? So I think I need to look at the publications. For me, which one is better? I would like to have longer follow-up to see more of hazard ratio. It's almost the same, identical. Now, and definitely, I would like to look for the price of those combination therapy. Is there any difference between the two? I don't believe there is a big difference. It's both of them. It's dual immunotherapy. I don't believe there is a big change between the two, but I would like to see the longer follow-up, and they're very important to look for the publication. I would like to see the exclusion criteria. I was asking, even I sent an email for the primary author to send me the exclusion criteria of this trial. They did not release it to me, or did not even, I think he did not see my email. Thank you.
Okay, Dr. Ashwaq, you have a question. I'm looking to the Q&A.
It is extension to your question, because this is a very diplomatic response, which is, I don't like it. It's like everything is good. Give me a good price, a discount. La. We need, you mentioned all the faults in all the clinical trial. You bring the beautiful tables for that.
Summarize, yeah.
So you know what's falls and this and that, but بطل دبلوماسية. You have an ideal patient, no contraindication to immunotherapy, no risk of bleeding. What you would choose first?
China.
So I mean, if you look for the most pronounced hazard ratio, longer follow-up of the patient,
أنا هذا اللي
it is atezo-befa, and there is
This
no
is
doubt.
this
I
is
mean,
the answer.
I will keep atezo-befa as a standard of care in hepatocellular carcinoma, except there is a contraindication. But again, we need to look for what's contraindications. We don't know about after 5 years from now, during your retirement at that time, maybe there is a longer follow-up. We will see more of pronouncing of hazard ratio in the either slide or in nivolumab EP. So I do believe, at the meantime, I think atezo-befa should be the standard of care, very pronounced hazard ratio. Keep in your mind the toxicity profile. My question to you guys now, again, if we have patient with esophageal varices and there is a risk of bleeding and it is written clearly by the GI endoscopist, it is controlled or it was fixed, do you think that we could use STRIDE protocol? Do you think that we would like to use atezo-befa in this patient? And number two, what about those who has a main portal vein thrombosis? We know the STRIDE protocol is excluded. What about the atezo-befa? This is this is a very important point because basically you remember the case I discussed with you 2 weeks ago, a young patient with huge mass in the liver, severe portal vein thrombosis, collateral everywhere. So what's the best treatment for this patient? He's child A and
Nivo-EP.
Yeah.
Because this is the highest objective response rate.
We don't know about those exclusion criteria. That's my question. What I did, I referred for Ashwat to tell me what I should do.
We have one more question from Dr. Madkhalin. Last question, Dr. Madkhalin.
My question is to Dr. Ali regarding gastric cancer HER2 positive. If those patients progress on first-line treatment, trastuzumab-based treatment, would you expose them to another biopsy to test for HER2 stain again, or just rely on baseline HER2 test?
So ideally, based on the clinical trial, then you need to biopsy. But practically, we don't do that. Most of the time, we just start with TDXD, a second line, without subjecting patient to another biopsy. But if you wanted to go by textbook, then you need to get another biopsy.
Yes.
Actually, there was a trial, and I think it's going to be this ASCO, TDX versus ramucirumab plus paclitaxel, and showed superior overall survival. So we don't know yet. They did rebiopsy again. I don't know what they did exactly in this clinical trial.
One more comment from Dr. Shamari.
My final comment is back to the esophageal varices challenge. I think we're underutilizing the hepatologist. The Jani report with grade 2 esophageal varices. To be honest, what I would do is actually lift up the phone and call the hepatologist and ask him what's the chance that this patient is going to bleed significantly. They get banded, they get nadolol, they always get a repeat scope 8 weeks later, and the majority of these patients get a significant reduction in their varices. And how many of them actually bleed? When I did real-world evidence of our patients treated by myself and Dr. Ashwag in National Guard, we reported 670 patients a couple of years ago in ESMO GI. And what I found is 1/3 of them have grade 1 to 2 esophageal varices. Only 3% actually get 3% get grade 3 esophageal varices. So a very small number that get significant varices. So I think maybe we're underutilizing.
Thank you, everyone. We can go to the next, Dr. Ashwaq, I think. A group photo. Okay, so can we have a group photo, please?
Okay, one more please. 1, 2, 3. Last one.
So break until 11:20.
Assalamu alaikum. Please be informed that we will be back in 5 minutes. I'm displaying the agenda for you for your kind information. We'll be sharing the link for the second attendance during the upcoming 20 minutes. Thank you all. See you in 5 minutes, inshallah.
والله يا اخي ها والله يا اخي صار عندي من ولا لا لا بس لا انا Listen, can you send me notification through WhatsApp? Yes. Yeah, it's easy. انا كل يوم بقول دايما اعطينا البلاي ستيشن ويجي الاسبوع تعرف بس اتكلم الناس كلها عندي كانت مو صح جي اي جبنا خبرات سويت الابديت خلاص هو شيء صدقه جاريه صدقه جاريه والله هذا RepNet versus لا 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 مؤسسة شركة
Sure. بدي. طيب بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. So we are back to what I think is the most exciting part of this talk, at least to me, which is the live molecular tumor board. So we're going to be presenting two cases. One will be presented by my dear colleague, Dr. Mohammed Al-Garni, and will be the genomics part is going to be presented by Dr. Faiza Al-Ataibi, and the other case is going to be presented by myself with Dr. Rihan Ajina as the genomicist. And I think we also have panelists, and the moderator is going to be Dr. Dua Al-Amoudi. So Dr. Mohammed, if you want to start.
Bismillah ar-Rahman ar-Rahim. So I'm going to start with the first case. I'm going to present the clinical part. Then Dr. Faiza is going to discuss the molecular profile. So the first case is a 60-year-old female. Dr. Faiza, can you move the slides? So is a pleasant 62-year-old female. She is a known case of diabetes and hypertension, and she has no family history of cancer. She presented to our ER with abdominal pain, and physical examination done in AR showed a palpable left upper quadrant mass. The CT scan showed a large splenic flexure thickening with aneurysmal dilatation versus contained perforation with multiple necrotic lymph node, highly suspicious of neoplastic process with possible mucinous component and no intra-abdominal solid organ metastasis. The colonoscopy showed large ulcerating mass at 60 centimeters from the anal verge. Next slide. So it was discussed in the GI tumor board, and the plan was to proceed with upfront surgery. So she underwent a major surgery, including left hemicolectomy with primary anastomosis, small bowel resection, and anastomosis, splenectomy, appendectomy, cholecystectomy, and gastric wedge resection, and DG anastomosis because the mass was adherent to the gastric wall. The final pathology showed poorly differentiated carcinoma with the tumor involved serosal surface. 7 out of 21 lymph nodes were positive, and the immunophenotype based on immunohistochemistry was non-specific for primary origin site, and appropriate diagnosis is poorly differentiated carcinoma of unknown origin. This is by pathology. So she had a CT scan chest that showed multiple bilateral lung nodule concerning within the context, and she has also left supraclavicular lymph node, highly concerning for metastasis. Next. So she was seen in our clinic. Her performance status was 2. She was recovering slowly from her surgery. At that time, when she came to the clinic, already immunohistochemistry was requested by the pathologist, and we added the foundation medicine one. So this is her result. She has loss of MLH1 and PMS2 in her immunohistochemistry, and the NGS result also will be shown and will be presented by Dr. Faiza. Please, Dr. Faiza.
Thank you so much, Dr. Mohammed, for introducing the case. So as you see, this is a very complex case of report. We have patient samples with microsatellite instability high, leading to increased tumor mutation burden of 35 mutation per megabyte. We also have the HRD signature, which is a homologous recombination deficiency, shown as negative. And we have a long list of different mutations that we're going to go through them one by one. We'll start with the MSH3 mutations and MSH6 mutations. And as you know, these genes are associated with rebearing mismatch repair deficiency. And so mutations in these twos will lead usually to increased microsatellite status high and leading to increased tumor mutation burden. Luckily, increasing of these two predictive biomarker in colorectal cancer usually is associated with improved response to immune checkpoint blockade. This figure here, or this study, showed a good response rate in tumors with increased mutation burden. It is important to mention that the threshold in this study was 73 to 41 mutation per megabyte. Our case here, our patient had a 35 mutation per megabyte, which is pretty much close to the threshold in this paper. Well, New England Journal of Medicine has published a study recently in 2014, looking at the impact of nivolumab plus ipilimumab in microsatellite instability high metastatic colorectal cancer. And as you see here in the orange line, a patient that received nivolumab plus ipilimumab responded better at a level of 72% compared to 14% in the chemotherapy-treated group. The grade 3 and 4 adverse event was even better in patients that treated with immune checkpoint blockade compared to the chemotherapy group. The second mutation here, we have the B10. And the B10 here is based on the OncoKB, is oncogenic. The other alternation is indicated as likely also oncogenic. Alternation in these genes seems to be more frequently correlated with large sided tumor, MSI high, BRAF mutations, as well as lymph node metastasis and high tumor stage. In the bioportal, it shows that they are common acting mutations that located in the phosphates domain, which is very important to mention, as we're going to show why here. So this paper here, they put the threshold as a 10 mutations per megabyte to consider high. And they found that patient with tumor that harbor B10 mutation in the phosphate domain, as in our case here, are associated with resistance to anti-PD-1 in gastrointestinal cancer. You can see this shown in the C figure and D figure in the blue line, where patients with this mutation had the worst progression-free survival as well as overall survival. So B10 loss or loss of function mutation is associated with resistance to ICI or immune checkpoint blockade in a wide range variety of malignancies. Then we looked at homologous recombination deficiency signatures. These genes, the CHEK1, CHEK2, and ART, are genes associated with repair in this homologous recombination deficiency. Although they are negative, yet the signature came up as a negative. And so this signatures usually is a biomarker developed and validated to classify homologous recombination deficiency status in a panel of cancer samples. It can evaluate genomic and non-genomic scars because of incorrect DNA double-strand break repair in homologous recombination deficiency. A positive of the signatures usually associate with response to PARP inhibitor. And so in the samples here, it harbors alternation in homologous recombination repair-related gene. However, it was the sample was negative. The threshold was 0.08. And this could be actually due to several factors, such as that the alternation being monoallelic or a passenger mutations. Now, then we have the or KMT2D mutations. These are both are likely oncogenic and likely loss of function mutations. The C-Bio portal shows that they are rare mutations, which associate with improved response to immune checkpoint blockade in colorectal cancer. Then we have the favorite biomarker in colorectal cancer, the BRAF in the V600E. This mutation granted an FDA approval in 2024 using encorafenib and cetuximab for treatment with the or mFOLFOX6 for metastatic colorectal cancer with this mutation. However, it's important to keep in mind that since this patient also harbored the B10 loss of function mutation, it could actually lead to resistance to PARP inhibitor. And this was concluded from an old study done in cell line or in culture, testing colorectal cancer cell lines with the mutations in B10, as it's shown to be less sensitive to growth inhibition by PARP inhibitor. Then we have the ARRF-L1 mutation, which is likely oncogenic. Loss of this mutation or an activation might result in EGFR activation and predict sensitivity to RBB tyrosine kinase inhibitors. Next, we have the RNF43 mutations, likely neutral. A meta-analysis of patient with a BRAF V600E mutation of cancer suggested that RNF43 mutation might predict improve clinical benefit from BRAF and EGFR combination therapy in the context of microsatellite table. But in this case, we do have microsatellite instability. So kind of two direction. Do we go through using immunotherapy or targeting BRAF V600E? This published study in 2020 showed that, or tested pembrolizumab in microsatellite instability high advanced colorectal cancer. They tested 25% of patients that do have BRAF V600E mutations. And they showed that patients with both either BRAF mutations or the wild type BRAF equally benefit from treatment with the PD-1 blockade. Last, we have the IDH1 mutation, which have level 3 evidence still under investigation, testing ivosidenib with immune checkpoint blockade. And I will leave it now to Dr. maybe Mohammed to go through this and then hand it to Dr. Nada for the pharmaceutical point of view. Thank you so much.
Thank you, Dr. Faizi. So basically, the molecular profile for this patient helped not only with the guiding therapy, but also with the diagnosis. So we know this is an MSI high colon cancer, locally advanced tumor, although the feature, as we all know, may seem aggressive and ugly under the microscope, but their prognosis is good. So when I saw this patient in the clinic, she had echo performance status of 2 post-surgery. She has no major burden of disease. She has multiple lung nodule and she has left supraclavicular lymph nodes. So the question was, and also we know now she has a BRAF P600E mutation. So we have a 2 mutation, and as presented by Dr. Faiza, 25% of the patient included in the Keynote 177 has these findings, which is MSI and BRAF mutation at the same time. So the question in the clinic, so what would be the ideal first line for this patient? Should we go with a single agent immunotherapy? Should we go with dual immunotherapy? And should we go with the conventional treatment, which is the chemotherapy followed by second line? Actually, I saw the patient before the approval of this encorafenib in the first line setting. So it would be interesting to know the opinion of our GI group. Would you go with a single agent immunotherapy or dual immunotherapy in this context? Dual? Okay. So actually, I started her only on pembrolizumab because she has a performance status of F2. She lost a lot of weight. She has no significant burden of disease by imaging. So she was started on pembrolizumab as single agent. She had 4 cycles of treatment. The repeated PET scan was done last week and showed no changes in the lung nodule. It was below the resolution of the PET scan. However, there is a very mild activity in the left supraclavicular lymph node. The patient is gaining weight and she's doing better with only single agent of immunotherapy. But I would agree with you, Kanaan, if I have the data of the NIFO-EB before, I might consider dual immunotherapy in this patient. Anyone would consider encorafenib cetuximab with FOLFOX as a first line? Okay. Okay, Dr. Anna, do you have any comment on from clinical pharmacology?
Assalamu alaikum. Good morning, everyone. My name is Nada Sahibani. I'll just be very quick because already we have chosen a therapy for the patient, which is Pempro, but I'm just gonna go theoretically. If we went with 2 options of these agents, whether IDH1 inhibitor or ifosfamide with IPI and Nivo, this agent can be we have to monitor as a clinical pharmacist the side effect, because these combinations usually we do not use it together. So my role here is to know if there is any overlapping toxicity that can be toxic for the patient. Drug-drug interaction, this is very important because if we use these medications together, and usually they're not used a lot in practice, I would check the drug-drug interaction between them. And also I have to check the patient profile. Does the patient take any other medication that might interact with these medication and make it more toxic? Another third thing that I have to do, which can be annoying for all of us, which is formulary option. Is it available in the formulary or not? Unfortunately, ifosfamide is not available in the formulary, and encorafenib, for example, also is not available in the formulary. So we have to be really fast, request these drugs as non-formulary. So, so these are really quick. And then next slide. So the next slide. Sorry. Okay, so the next slide, if we went with the encorafenib with cetuximab and FOLFOX, which can be a very toxic option. And here we have to be very careful because there is actually overlapping toxicity, especially, for example, cardiotoxicity, skin toxicity, and even hepatotoxicity. So here can be beneficial. For me, as a pharmacist, I would advise to use prophylactic drug for the skin toxicity, the acneiform toxicity, because here 100% of the patient will get it, especially in the first 2 weeks. So for example, topical steroid can be an option, topical antibiotic can also be an option, because after that it can subside after the first month. So that's all what I have from a clinical pharmacist standpoint. Thank you all.
Thank you so much, Dr. Nada. Thank you so much, Dr. Faiza, Assistant Professor in King Saud University of Health Science. Thank you, Dr. Mohammed Al-Garni, for this insightful case.
Yes, go ahead, Doctor.
Can you hear me, Doctor?
We can hear you, Doctor.
Yeah, okay.
From the audience.
Okay, now we will move to the second case with Dr. Kanaan.
Doctor, just give us a minute because we have a question from the audience.
Sure. Any questions for Dr. Mohammed case?
Yes, so thank you so much, Doctora, for your nice moderations. Special thanks for Dr. Mohammed for this nice case. So let me ask you, I mean, those who has very high tumor burden mutation, those who has more than 40 and 50, we are seeing some reports. What's the implication in the first line therapy? I mean, do you believe that IO should be the standard of care with those very high tumor mutation burden, more than 50 or 60? Or shall we go with the chemotherapy and keep the TMB, I mean, options as a subsequent line of therapy if we could consider? So what's your advice? I mean, we are seeing some patients with a very high TMB in the first line setting. And the big question, shall we go with the immunotherapy? Shall we go with the chemotherapy? And I will tell you, go ahead, and then I will tell you exactly one of the cases with a high TMB, went to MD Anderson, and I will tell you what's the medication they start on.
It's a very excellent question, Dr. Abdullah. So when you have such high tumor mutation burden, it's usually associated with certain type of molecular profile like Lynch syndrome, or in colon cancer with Pol mutation. Those patients, they have really very high tumor mutation burden, and those patients, I would go with the first line immunotherapy. Now, when it comes to if I have such high tumor mutation burden without these two mutation either in the Lynch syndrome genes or Pol, I would go with the first line chemotherapy, then I might consider immunotherapy in the later lines of treatment.
So can I?
Yes, I have a comment, Badr, which is tumor mutational burden should not be treated the same between different tumors. I agree with Mohammed that it is associated with Lynch syndrome and it is associated with Pol/Pol D mutations. I'll give an example. In our molecular tumor board, the first thing we do if we get a tumor mutational burden of 7 in the cases that I treat of leiomyosarcoma, and I do a lot of sarcoma. I have had a case of leiomyosarcoma, exhausted many lines of therapy, tumor mutational burden of 6. So there's no FDA approval for immune checkpoint inhibitor, but we went back and we saw what's the median tumor mutational burden in all published cases of leiomyosarcoma. The average tumor mutational burden was between 2 and 3. So 7 is actually double that number. Based on this, somehow we came up with the recommendation. It was a weak recommendation, and not really backed up by solid evidence of giving immune checkpoint inhibitor. I gave the lady Nivo-Ipi. She died a couple of years ago, but she responded 6 months as a 6th or 7th line. So we have to look for the average tumor mutational burden for the disease site. For example, in malignant melanoma, the standard of care is either immunotherapy or BRAF inhibition if the patient is BRAF positive. The median tumor mutational burden for melanoma is around 60. So if your tumor mutational burden is below 60, there is some weak level of evidence that these patients may actually not respond to immune checkpoint inhibitors. So what happened to the patient, Dr.
So you think that TMB is a predictive marker in immunotherapy. However, is not believing in the first line setting. That's what I understand from you guys. So what happened exactly? They start the patient on FOLFIRI plus one of the immunotherapy, rituximab or
Rialtimab.
Rialtimab, yes. Yeah, and they send the patient to us. I don't know what I should do with this patient.
And this was on a clinical trial?
No. This is their recommendation, and they send the patient to this medication. So medications are available. So I do believe that if you look for the data that mentioned by Dr. Ali Faqih, that the TNP per se is not a predicting to respond to the immunotherapy. And those who has a TNP and high MSR, those or Lynch syndrome, they are the one who are responding. So I do believe TNP in relation to the immunotherapy, I do believe it's not in the either setting. This is what I think. Thank you.
Thank you. So I'll start with the second case presentation. So this is a challenging case that I'm currently treating in my clinic of a 60-year-old man with metastatic biliary tract cancer. So he's 65, diagnosed in September of 2023 with metastatic biliary tract cancer to the liver. The primary was, I think, gallbladder adenocarcinoma. I gave him first-line carboplatin gemcitabine durvalumab for 4 cycles. He unfortunately progressed very rapidly. Then I gave him Folfox as second-line therapy for 6 cycles, followed by a scan which also showed progressive disease. His performance status at that time was still actually good at 1. So we ordered next-generation sequencing, and I'll give the podium to Dr. Riham Ajina, who's an assistant professor and a cancer immunologist in the University of National Guard.
First, I would like to thank the organizers for inviting me to present the case here today. Okay. So as you all know, the biliary tract cancers, there are 3 major types: the intrahepatic, extrahepatic, and the gallbladder. And this patient had the gallbladder cancer. And according to the NCCN guidelines, we need to do, or it's recommended to do molecular profiling. So this is the FMI report that we received. The upper part is the, as you can see here, the upper part is the biomarker findings, which include the microsatellite status and the tumor mutation burden. And then there's the genomic findings. According to the microsatellite status, the patient is MS stable. So in this study, they included all the 13 studies with about more than 1,000 gallbladder cancer patients. And most of these patients, only 3.5% of them had microsatellite instability high. In other words, so this patient just belonged to the most cases of gallbladder cancers. This study shows the median tumor mutation burden. So as Dr. Kanhan said, we need to study each type of cancer specifically to know the median TNP. So according to this review article, 3 studies reported the median TNP. The first one in India, the median TNP was 5, ranging from 1 to 14. The other one was 7.03. And this was in China. The third study was in the US, with the largest number of patients included in the study, and the median was 2.6. So since this patient, the tumor mutation burden was 2, so it's in all cases, it's below the median, so this patient is not, or most likely will not benefit from immunotherapy. So what about the other genomic findings? This patient has 7 mutations, and all of them are amplifications. Interestingly, 4 of these genes are located in chromosome 12 and 3 are located in chromosome 20. So focusing on the upper ones, the ones that are located in chromosome 12, according to a CPI reported datasets, which includes 1,366 gallbladder cancer patients, you can see that KRAS, MDM2, ERB3, and CDK4/6 are not very rarely mutated in this type of cancer. about 10 to 4%. And most of these mutations are here colored in red, which means amplifications. One patient only had amplification in all the 4 genes, and 7 patients had amplifications in the 3 genes, MDM2, RB3, and CDK4. According to C-portal analysis, patients who have alterations in these genes have worse overall survival, shown here in red, compared to patients who don't have alterations in these genes. A very recent paper published in Nature Communications showed that if the patient had in colorectal cancer patients who have amplification in KRAS, it is common to have amplifications in CDK4 and MDM2, which is similar to our case. So let's study these genes specifically. We have CDK4, and as you all know, it's a key player in the cell cycle. And what it does, it binds to CDK6 and then cyclin D1. This tri-complex then phosphorylate RP, which is a tumor suppressor. When it's phosphorylated, it's released from E2F, which is a major transcription factor. This allows E2F to be free and bind to the DNA, allowing for cell cycle and tumor progression, the cell cycle progression and tumor proliferation. So should we target CDK4 with a CDK4/6 inhibitor? Two clinical trials have asked this question. They used monotherapy of CDK4/6. The first one to the left used palbociclib. The one to the right used abemaciclib. And as you can see in both studies, the first one included 10 gallbladder cancer patients. None of the patients had objective response or stable disease after 16 months. To the right, the clinical trial was terminated. So what about the other genes? We have KRAS, MDM2, RB3, SART, and ZNF217. All of them belong to the MAP kinase, AKT, PI3, AKT, and mTOR pathways. As you can see here, we have RB3 in the top, which is a receptor, and then we have KRAS, and then we have MDM2. We also have ZN217. ZNF217 stands for zinc finger protein transcription factor, and it has been associated with proliferation and worse outcomes in patients with osteosarcoma, ovarian cancer, breast cancer. In the study shown here and below, they showed that this particular gene can actually regulate the AKT pathway. So we have this MAP kinase very active, and PI3 AKT pathway is very active. And all of these pathways can, as you can see here in the bottom, can regulate or activate CDK4. In fact, there are many mechanisms of resistance to CDK4/6 inhibitors. One of them is the activation of PI3 AKT pathway and MAP kinase pathway. So based on that, we recommended that the patient should be use medications that target the RB3, the upper part of this pathway, and then CDK4. And as you all know, with the RB family, which consists of 1, 2, 3, and 4, we have RB3. It can bind, so it's, as you can see in 3, so it's 3 and 3, which means RB3 that autodimerize, or 3, which stands for RB3 that can dimerize with HER2. So to target RB3 either as an autodimer or as a dimer with HER2, we need to use a drug that targets specifically RB3. And among the many molecules that can target the RBB family members, only afatinib can target RBB3. So we decided to use afatinib in combination with CDK4/6 inhibitor. In preclinical settings in different models, so including head and neck squamous cell carcinoma, non-small cell lung cancer, esophageal squamous cell carcinoma, the combination of both afatinib and CDK4/6 inhibitor xenograft models were very effective. So shown here in the first figure in red compared to monotherapy, and then the second figure in the middle in blue and in the dark red to the left. So in all cases, there was very significant reduction in tumor size. So what about the clinical settings? There are two different reports. The first one is a case report of a patient with lung squamous cell carcinoma who had EGFR mutation, CDK4 amplification. The patient responded to the treatment. The second one is a clinical trial that's currently ongoing, but in esophageal cancer. So based on all these evidence, we decided that our recommendation is afatinib with palbociclib. However, afatinib was not available, so we had to find another way to target these mutations. So as you recall, ERB3 can also dimerize with HER2. And HER2 is, according to the NCCN guidelines, it's part of the therapy for gallbladder cancer patients. However, we were afraid that this patient would have acquired resistance since the patient has the main target is the main mutation is in ERB3. So to avoid this acquired resistance, we decided to treat the patients with a MEK inhibitor. So we'll have targeting the ERB2 for, in the up, and then MEK inhibitor, and then CDK4. And it has this been validated in clinical or preclinical studies? Not the three drugs combination, but the two drugs, palbociclib or the CDK4/6 inhibitors in general, with MEK inhibitors have been validated in preclinical studies in many models, and also in a retrospective clinical study where they evaluated the patients who were treated with MEK inhibitor and have genetic alterations in this pathway, with genetic alterations in CDK4 or CDK6 pathway, and these patients were treated with this combination. They had some response to the treatment, but not, as I mentioned, the three drugs together. So our recommendation was to use trastuzumab and palbociclib with trametinib. With that, I will ask Dr. Neda to continue.
Thank you, Dr. Reham.
Thank you, Dr. Reham. So this case was a little bit complicated for us, especially with the triple drug therapy combination. As you can see, I highlighted and bolded things that overlapping toxicity across different agents. For example, trametinib with cardiomyopathy, and trastuzumab can cause also cardiomyopathy, VTE, and also palbociclib has a questionable thrombosis, interstitial lung disease, pneumonitis. So all of these can be worrisome for us in terms of overlapping toxicity. So here, when we discussed the case, myself and Dr. Kanan, we decided to start with a lower dose with trametinib. Instead of giving the full dose of 2 milligrams, we gave the patient a lower dose of 1 milligram. We give palbociclib a full dose, and then trastuzumab. We start with a loading dose, and then followed by 6 milligrams per kg every 3 weeks. Here we have to be really careful with monitoring, like echo at baseline, LFT, CBC with differential, and then monitoring echo every 3 months. Since the combination can be confusing, I made a calendar for the patient that can be easier for the patient to understand the therapeutic plan. With especially palbociclib is 3 weeks on, 1 week off, and trametinib we wanted to start at a lower dose, and then we can increase if the patient tolerated the agent very well. And as you can see in the fourth week, I highlighted in yellow just to indicate that's the week will be off where the patient will not take palbociclib, just to ensure, because it can be very toxic, and I want to ensure the patient doesn't mix the drug or misunderstand the agent, especially if you want to start a patient a new agent, they always get overwhelming for them. And then I put a note that trastuzumab will be in the hospital every 3 weeks. Okay. That's all I have from a pharmacist standpoint. If you have any questions, please let us know.
Thank you, Dr. Neda. Thank you for this insightful information. Is there any questions from the audience?
Let me present what happened to the patient. So to my GI oncologists, so this is a guy in his 60s who progressed on platinum gemcitabine durvalumab, who then progressed on FOLFOX, which is standard of care. Performance status was excellent, and his next generation sequencing result showed CDK4 amplification, MDM2 amplification, HER3, not HER2, HER3, so ERBB3 amplification, and a few others, and he was microsatellite stable, tumor rotational burden of 2. And with the discussion in our molecular tumor board, this case was analyzed by Dr. Riham. We came up with the recommendation of a CDK4/6 inhibitor, palbociclib, and due to the oncological or the oncogenic pathway, a recommendation with HER3. The recommendation also was for a MEK inhibitor and a Herceptin anti-HER2 agent. So I started the patient on palbociclib 125 milligrams daily for 3 weeks on, 1 week off. Trametinib 1 milligram daily rather than 2 milligrams after consulting with Dr. Nada due to expected toxicities, and Herceptin, the usual dose, intravenously every 3 weeks. The baseline, before we actually started, and we started therapy in late July of 2024. The baseline CA19-9 was 11,410. After approximately a month, came down to 9,331. And after 2 months, it came down to 3,001. After about 6 weeks, it started to go up again. However, the patient was still clinically tolerating and responding. And we had, to be honest, we had difficulty managing the myelosuppression, and we actually came down with the dose of palbociclib to 75 milligrams daily for 3 weeks on and 1 week off. For some reason, I couldn't really capture the image to put the picture of the image here, but I put the reports here. So his initial scan was in mid-July of 2024. It showed progression after FOLFOX. We were doing scans every 6 to 8 weeks after. By RECIST criteria, he had stable disease, but he had mild reduction in his size of liver and lung metastases. In December, by RECIST, he was stable disease, but also there was a mild reduction of about 15% in the size of metastases. Then in February, he had progressive disease in the form of worsening of lung metastases. His liver metastases, his abdominal lymphadenopathy was actually still under control with stable disease. But this patient remained on this MTB recommended precision therapy, which is not really FDA approved. However, we're in the 3rd line setting, and we did put him under the research protocol of our precision oncology platform. He remained on this 3rd line therapy for about 7 months. He is currently on chemo break. I gave him a chemo break during the holy month of Ramadan. He came to me last week. His son is going to bring him. His son is a physician mana. His performance status is 2. So the question to my GI oncologists, what is next?
Chemo.
What chemo? Yeah, I'm planning for FOLFIRI. Okay. Any questions regarding this case? Go ahead, Dr. Abdullah.
Yeah. So thank you so much, Kanan. So Kanan, if you look for the anti-MEK, remind me, in anti-MEK, all the trial of anti-MEK, it was completely negative. Even with the colorectal cancer, when they combined the triplet versus doublet, anti-MEK was out. So do you think still are we, I don't know about the other type of tumors, even in melanoma it was negative.
And MEK inhibitors, actually they are FDA approved in melanoma.
Yes,
when combined with BRAF.
Yeah, but
however, when given as a single agent, I fully agree with you, they don't work. They are in the MAPK pathway, but they give you deeper responses if combined within the MAPK pathway. Even with EGFR inhibitors, there is actually phase 2 data in colorectal cancer. When we combine panitumumab with a MEK inhibitor, responses are deep, but they're not long-lasting. Here we added the MEK inhibitor due to the possibility of a resistance mechanism, and hence we added it because of the HER3 inhibition with Herceptin and the CDK4/6 inhibitor. So that's why we added it, and to be honest, it gave us a progression-free survival of 7 months.
What about the TDX if the ERP is strongly positive +3?
مشكلتها HER3 not HER2.
HER3 oh sorry.
HER3 بالضبط. For HER3 we actually found that afatinib has some form of يعني action against HER3. But afatinib, I think, is long gone after the discovery of osimertinib in lung cancer.
Very interesting case. Thank you, Kanaan.
طيب, any other questions?
I have a question, Dr. Kanaan.
Go ahead.
Would you consider to send another sample, like a liquid biopsy, to follow up with the patient and her genomic profiling?
Excellent question, Victoria. To be honest, I'm not going to do it. I'll give him chemo. He's not really in the best of physical shapes. And if I repeat it, I don't really anticipate major changes in his genomic profile. And we don't really have any evidence for this. And we have evidence of repeating NGS, probably in breast cancer because of the HER2 story. We have weaker level of evidence for gastric cancer for repeating NGS, again for HER2. And we have stronger level of evidence in repeating NGS in non-small cell lung cancer in the earlier generation TKIs that target EGFR. In this case, we really don't have a lot of evidence, and unfortunately, his performance status is not the best, so I'm not really investing in performing another NGS.
Clear. Thank you very much, Dr. Khan. Is there any other question?
Thank you very much.
Okay, thank you very much for this insightful, and thank you for sharing your expertise and your knowledge. It was very helpful and excellent presentation. Thank you very much.
Thank you, Dr. Dua. I also thank the speakers and panelists. So I think now we have the prayer and lunch break, and we should be back at 1 p.m. Thank you.
Assalamu alaikum wa rahmatullah. We would like to thank you all for your time and effort and attending these two scientific days. Please be informed that the registration link will be sent at the end of the conference. So it will be sent at the end of the conference. Please make sure to fill all of these forms, and please make sure that you are among the target audience so you can get your CMEs without any problems. Thank you all. We'll see you at 1:30. Thank you very much.
Good afternoon. Assalamu alaikum, Dr. Walid. I cannot hear you.
Can you hear me now, Dr. Samah?
I can hear you. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Muhammad, for the kind introduction, and thank you, Pfizer, for the invitation to chair this satellite symposium. Today we have the satellite symposium by Pfizer company, which will be about the CROWN trial 5 years update in the management of non-small cell lung cancer ALK mutant as a first-line treatment. Our presenter is Dr. Samah Al-Rahili, who's a non-medical oncologist at Prince Noor Medical Center at King Abdulaziz Medical City with interest in GI and lung cancer. Dr. Samah, the floor is yours.
Assalamu alaikum. I would like to thank Pfizer and also the organizing committee and Dr. Walid. Today, I will actually talk about the CROWN trial, the 5-year update. This is my disclaimer. So focusing on the 5-year update from the CROWN data, as we know that there is an evolution of first and second generation ALK inhibitors. And we know that as we go in the advanced from one generation to another generation, there is an increased in potency, selectivity, and increased in the CNS penetration, and also increase in the activity coverage of the on-target resistant mutation. When we look at the CROWN trial, it is actually the eligibility criteria is in stage 3B and 4, no prior systemic treatment for metastatic disease with the excellent performance status, asymptomatic, treated or untreated CNS metastases. They were randomized to lorlatinib 100 milligram once daily or crizotinib, which was the standard of care at that time, with the primary endpoint of progression-free survival. Focusing on the current post-hoc analysis at 5 years, at 60 months of median follow-up, median PFS by investigator was still not reached with lorlatinib, with a hazard ratio of 0.19. When we look at the progression-free survival rate at 60 months is 60% for lorlatinib versus 8% for crizotinib. When we look at subgroup analysis favoring the use of lorlatinib, significant and impressive result when we have a brain metastasis with a hazard ratio of 0.08, and also good, an excellent actually hazard ratio with no brain metastasis 0.24. Again, this is if we have a baseline brain metastasis and without a baseline brain metastasis. When we look at the time to intracranial progression by investigator assessment was longer with lorlatinib. At 60 months, the hazard ratio is 0.06, and actually the rate of intracranial progression patient without intracranial progression percentage, 92% at 60 months versus 21% in the crizotinib arm. The time to intracranial progression was longer with lorlatinib in the presence or absence of baseline brain metastases. And when we look at the evaluating CROWN in the context of ALK treatment landscape systemic efficacy, if we look at actually lorlatinib at 5 years, is actually 60 not reached at 60 months. And if we look at compared to alectinib and brigatinib, actually lorlatinib is significantly better than other agents that we used in the past. Brain metastasis is very important because it's very common in ALK inhibitor in ALK positive patients. And actually, if we look at brain metastases are common at initial diagnosis by 25 to 40% and a cumulative more than 70% at 5 years. Despite CNS activity of second generation ALK TKIs, CNS relapses with alectinib, 12 months cumulative incidence rate for CNS progression is 9.4. For first-line brigatinib at 3 years, intracranial PFS rate is 57%. So the 92% at 60 months is actually something very significant and that we did not see in previous medications. When CROWN initially presented, everyone was anxious and worried about the toxicity, but now with time, we know that the toxicity is manageable. If we look at actually the toxicity profile, edema, high cholesterol, high triglyceride, and also weight gain, increase in AST and ALT, but generally manageable. And CNS toxicity was also one of the toxicity that was actually concerned. When we got the update from the 5 years, they found that there is no new safety signals identified after 5 years of follow-up, and all-cause adverse event and treatment-related adverse event leading to treatment discontinuation, all-cause was 11% and treatment-related adverse event was 5%. And the reassuring part is actually even with dose reduction in the first 16 weeks, did not impact efficacy of lorlatinib. And this is very important. So if we look at the progression-free survival and time to intracranial progression, it did not get affected by dose modification in the first 16 weeks. When we look at the lorlatinib treatment benefit in patients with poor prognostic biomarkers, if we look at the EML ALK fusion variant 1 and 3A-B, it favors the use of lorlatinib similar to a TP53 status. The other thing is when we use lorlatinib upfront, actually the resistant mechanism is actually by bypass mechanism, and there is no new signal ALK mutation found and no ALK compound mutation found. So it's mainly bypass mechanism. And the conclusion from the CROWN update is after 5 years of follow-up, median PFS has not been reached and PFS was 60%. The probability of being free of intracranial progression was 92%, and there is no new signal, safety signal emerged. And the PFS observed with lorlatinib corresponds to the longest PFS reported in advanced non-small cell lung cancer. And this systemic efficacy result, coupled with protection from intracranial progression and absence of new safety signals, indicates that first-line lorlatinib provides unprecedented improvement in outcome for patients with advanced ALK positive. If we look at actually comparing lorlatinib to other agents, this is actually from the 3 years update, not the 5 years update. But what I want to highlight here in the slide is lorlatinib efficacy is actually significant when we use it as a first line. If we look at using of lorlatinib as a second line, PFS after alectinib or brigatinib was around actually 5 months. So we are learning more and more in lung, and now we know that using the best medication upfront is the best strategy for our patient. The other thing is if we use alectinib and brigatinib as a first line, there is around 39 or 41% of patients that will not be able to receive a subsequent therapy after the first line. And this is something that we need to keep in mind. When we look at the NCCN guidelines, lorlatinib is a category 1 recommendation with brigatinib and alectinib. And also if we look at the ESMO guidelines, it is also in the recommendation. And with this, I conclude my presentation. Thank you.
Thank you, Dr. Samah. Can you hear me now?
Yes, I can.
Thank you for clarifying the update 5-year survival and CROWN trial. So as clearly evidenced by the trial, we have excellent PFS and overall survival data. So my question for you now, like we are always concerning about any new medication. So you mentioned about the side effects and the dose reduction, and it did not affect the survival. So my question, if you have someone with poorly controlled diabetes mellitus, like blood sugar is uncontrolled, lipid profile is not controlled, would you consider starting with the lower dose and titrate up, or go with the full dose, then titrate accordingly?
Well, controlling the current actually medical history is very important before considering lorlatinib, because as you know, for example, for the dyslipidemia, it is happening in around 90% of the patients. So almost every patient will suffer or have some kind of actually dyslipidemia. So what I would prefer actually controlling the pre-existing medical condition before considering lorlatinib. But because as you know, also ALK patient, usually their disease is aggressive. So maybe starting with 50 or 75 milligram and then modifying their pre-existing medical history and then increasing the dose to the maximum. I think generally all the pre-existing medical history is okay. If I have a CNS or a psychiatric history, I want to make sure that it is well controlled before considering lorlatinib.
So any questions? So thank you, Dr. Samah. So I think by this we'll end our satellite symposium. Thank you, Pfizer, for the kind invitation. So we can proceed now to the session 5, GU-Gynae. And the moderator will be Dr. Walid Al-Salwi, who's a medical oncologist at King Fahd Specialist Hospital Dammam. Dr. Hashim Al-Hashim, who's also a consultant medical oncologist at the King Khalid University Hospital. And Dr. Abdurrahim Mishangiti, who's a medical oncologist at King Fahd Specialist Hospital Dammam.
Assalamu alaikum warahmatullahi wabarakatuh. Thank you, Dr. Reed. We kindly thank you, Dr. Muhammad, Dr. Kanaan, for inviting us for the 5th time for this excellent meeting, very selected meetings to discuss the updating on the precision medicine. And we'll moderate the session with Dr. Hashim Al-Hashim, the consultant medical oncology at King Saud Hospital, and Dr. Abdurrahim Al-Shanqiti is consultant medical oncology at King Fahd Specialist Hospital Dammam. I will start with Dr. Hashim. Please, Dr. Hashim.
Okay, thank you, Walid. And I would like to congratulate Dr. Kanaan and Dr. Muhammad for success of such a meeting. And I will invite the first speaker. The first speaker is Dr. Tal Bukhari. Dr. Tal Bukhari is a senior medical oncologist with specific focus on geo-oncology. He will talk about a personalized approach to prostate cancer. So we're waiting for Dr. And also, I want to welcome Dr. Abdurrahim, who is joining us online. Dr. Abdurrahim.
Assalamu alaikum, everybody. I hope everybody is doing fine. Enjoying the afternoon, inshallah. Class race. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم. First of all, I would like to thank Dr. Mohammed Al-Garni, Dr. Kanaan Al-Shammari, and the entire organizing and scientific committee of this conference. Great speakers, great topics. Inshallah, attendees learn something new from me, inshallah. Thank you to Dr. Walid Al-Sulwi, Dr. Hashim Al-Hashim, and Dr. Abdul Rahim, and all moderators. And my topic today would be about personalized approach in prostate cancer. This is my relevant disclosure. And I'm gonna cut to the chase and go directly and speak about personalized approach in prostate cancer. So question is there any personalized approach in treating localized or locally advanced prostate cancer? So the answer is no, as of April 2025. What about utilizing the personalized approach in metastatic hormone-sensitive prostate cancer? By actually mentioning that, I'm referring to molecular profiling, actionable mutations. Of course, we rely on multiple clinical factors such as performance status and comorbidities, but the answer remains no as of April of 2025, not yet. What about the role of personalized medicine in metastatic castrate-resistant prostate cancer? Can you give me an answer, guys? Yes or no? If it was a no, there would be no prostate cancer session today, right? There would be no invitation. So there is actually a role for personalized medicine in metastatic castrate-resistant prostate. Before actually moving towards this part of my presentation, we have to agree upon definition of castrate-resistant prostate cancer. So typically, it's disease progression, biochemical or radiological progression in the context of having castrate levels of testosterone, which is less than 50 nanograms per deciliter. Speaking about the personalized approach, these are the biomarkers and the actionable mutations that we typically use in our daily practice when treating metastatic castrate-resistant prostate cancer. We use human recombination repair proteins. We throw MSIs occasionally. I have to admit that sending for next generation sequencing, looking for tumor mutational burden is not something we do on a routine basis, and it's not funded in many, many institutions. One of the things we actually look at and discuss with nuclear medicine prior to giving lutetium-based treatments is the PSMA avidity. And we're going to talk about that. So what are the available medicines for castrate-resistant prostate cancer? Chemotherapy has been there for over 20 years. We use taxane-based treatments such as docetaxel, cabazitaxel. We also use novel hormonal treatments. The FDA-approved ones for castrate-resistant prostate, metastatic castrate-resistant prostate cancer is enzalutamide and abiraterone. We also use radioactive-based treatments such as radium-223 and lutetium-617. Lutetium PSMA 617. We also use other agents, and that depends on the molecular profiling results, such as PARP inhibitors, which will represent a good chunk of our presentation today. I'm just going to go to the previous slide. So this is how the NCCN guidelines look like. Extremely crowded and busy. There are some of those agents that are not typically used by GU oncologists when treating castrate-resistant prostate cancer. And we actually identified and highlighted that clearly in the MENA version of the NCCN guidelines, which was led by our brothers in National Guard Hospital here. So those are the mechanisms of DNA repair pathways. So the one we are concerned of is the homologous directed repair, the HDR pathway or the HRR pathway. So this actually pathway involves proteins that are in charge of repairing DNA breakdowns, single-stranded and double-stranded breakdowns. By having a mutation in a protein like BRCA1, BRCA2, or ATM proteins, what happens is PARP enzyme comes in as a rescue measure and as a salvage enzyme to help repairing those cells. Therefore, PARP enzyme is thought to be a very good target for patients with HRR mutations. Again, this is the target of the PARP enzymes. I'm going to speak about the agents that are FDA approved in targeting this enzyme. So the entire PARP inhibitor business started over 10 years ago by Johan de Bono and his colleagues from Royal Marsden, UK. Over 10 years ago, they published this first trial looking at the effect of olaparib in those patients. It was a small-scale trial that looked at 49 patients after having the hypothesis of metastatic castrate-resistant prostate cancer having the HRR mutation of 25%. It was thought prior to conducting this trial that around 25% of castrate-resistant prostate cancer patients will harbor one of those mutations, especially BRCA1, BRCA2, and ATM mutations, and many, many other mutations. So the take-home message from this small-scale trial is that olaparib showed response in HRR mutated patients. HRR mutated patients were BRCA1, BRCA2, and ATM, as I mentioned. TOPARP-B was a bigger scale phase 2 trial with the same concept and confirmed the responses of olaparib in those patients. TOPARP-A and TOPARP-B prompted conducting a phase 3 trial, which was profound trial where olaparib was looked at on a bigger scale. So basically patients with metastatic castrate-resistant prostate cancer who received prior lines of treatments were divided up into cohorts, 2 cohorts. Cohort A that contained patients with BRCA1, BRCA2, and ATM, and cohort B that had the other HRR mutations. Each cohort actually, patients in each cohort were randomized to either olaparib or physician's choice of treatment, with the primary endpoint, the radiological PFS, and many other secondary key endpoints such as overall survival. So the trial met its primary endpoint, and there was a clear benefit observed in patients who received olaparib. I'm just going to pull up the overall survival, which was again statistically significant in favor of the group that received olaparib. So again, the benefit was observed only in cohort A patients that had the mutations, and most of the benefit was observed in patients with BRCA1, BRCA2 mutation in this trial. PROPEL was a different trial that had patients who received prior lines of treatment in hormone-sensitive setting, but it was the first-line treatment as metastatic castrate-resistant prostate cancer, randomized those patients to either abiraterone versus abiraterone and olaparib with the same primary endpoint, radiologic PFS, which is the most popular primary endpoint in prostate cancer trials these days. Overall survival was one of the key secondary endpoints. And again, This trial actually met its primary endpoint, which was radiologic PFS, and was clearly in favor of abiraterone and olaparib in the ITT population. It was the overall survival was statistically significant only in HRR mutated patients, and that was actually clearly highlighted in the update that was published 2.5 or 3 years later, which showed the separation of the curves here in HRR mutated patients. If you look at the right side, you'll find out that the benefit was more observed in BRCA1 and BRCA2 mutated subgroup. So another trial with a different PARP inhibitor, same concept, but this time patients with chemotherapy naive, and were randomized to either physician's choice of treatment versus rucaparib. And I'm not sure if you guys treat gynae, Hashim and Walid. You probably have more experience with rucaparib more than any other geo-oncologist. Same primary endpoint. The trial met its primary endpoint. And based on the results, FDA approved this agent in the treatment of metastatic castrate-resistant prostate cancer. But there was a little problem. First of all, the initial results did not show any benefit in ATM group, and the RPFS advantage was only observed in BRCA mutated patients. The update, however, published last year, trying to yeah, this one. So this is the overall survival data that was just published last year, and it showed no statistically significant overall survival advantage of this subgroup, and this patient population. Magnitude, again, different combination with the different PARP inhibitors, targeting the same patient population, metastatic castrate-resistant prostate cancer. Again, the patients were divided to 2 cohorts, HRR positive and HRR negative, randomized each cohort to niraparib, a different PARP inhibitor, and abiraterone. Again, the same primary endpoint of RPFS with key secondary endpoints with overall survival being on top of them. So it met its primary endpoint, and the moderators can give me a guess what happened to overall survival? No. So statistically insignificant overall survival benefit towards the new combination. But the newer kid in the block was more interesting. And I'm not sure if you guys are using them, these talazoparib or not. No, not yet. طيب الحمد لله سبقناكم في حاجة. طيب again, same population, this time with talazoparib enzalutamide versus enzalutamide. Same primary endpoint of RPFS, overall survival as a key secondary endpoint. There was a significant number of non-HRR mutated patients. Each cohort, again, was randomized to either talazo-enzalutamide versus enzalutamide. This time, the initial result showed overall survival advantage in favor of talazoparib enzalutamide, and the RPFS was again in favor of the new combination. And based on the interim results published almost 2 years ago, it gained FDA approval. The good news is all subgroups benefited, with the most benefit observed in BRCA1 and BRCA2 mutated patients. Even non-BRCA1, BRCA2 HRR positive patients benefited from talazoparib enzalutamide. Not only this, even non-HRR mutated patients had a 9 months survival advantage that was in favor of talazoparib and enzalutamide. So based on this, they are all FDA approved, but olaparib alone or in combination with abiraterone for prolonged, life prolonged in PSA mutated patients and HRR mutated patients. In rucaparib, there was no significant overall survival benefit. Combination of niraparib and abiraterone showed no significant overall survival benefit. However, talazo and enzalutamide overall survival advantage was clearly observed in HRR and non-HRR patients. So the second tool we use as part of our personalized approach is the PSMA avidity as a predictor of response. So you guys are all aware of or at least patients who treat GU are aware of Vision trial that was published 5 years ago, enrolling patients with metastatic castrate-resistant prostate cancer and randomize them to either standard of care treatment versus lutetium PSMA 617. But because it was one of the oldish trials, overall survival was a primary endpoint, and the radiographic PFS was also primary endpoint, but at least they placed overall survival as a primary endpoint. This trial met its primary endpoint, and the overall survival was clearly in favor of lutetium PSMA 617. This was the percentage of patients without disease progression, and again, this was clearly in favor of lutetium PSMA 617. The interesting finding is the trialists actually who conducted this trial analyzed the patients and broke them down into different groups based on SUV uptake and PSMA avidity. They found out that the higher your SUV, the more benefit you're going to get. And you can actually see the line here, the blue line that represents the patients with the higher SUV uptake. So those patients had the best RPFS and patient population enrolled in Vision. And that applied RPFS, and it also correlated strongly with overall survival. So everything Abu Anwar Abdurrahman Naim told us was 100% true. And inshallah, patients benefit from this modality. So the higher your SUV, the better your RPFS, the better your overall survival. Unfortunately, if the patient is low grade, PSMA avid, even with lowish SUV, you cannot exclude them from this. So it's still there as a modality of treatment for all patients with metastatic castrate-resistant prostate cancer that have no high-grade disease, as mentioned by our colleagues from nuclear medicine long time ago. So there's another phase 2 trial that looked at the same patient population, therapy trial, published a year or two after Vision. It was a phase 2 randomized patients to either lutetium 617 versus cabazitaxel. And they were a little bit more strict when it comes to inclusion criteria. This treatment was given as second-line treatment. In Vision, they allowed patients with 3 lines and 4 lines of treatment. After a median follow-up of 13 months, the PFS, the primary endpoint was different this time. It was a PSA decline of more than 50%. It met its primary endpoint. There was a slight benefit in terms of PFS in the lutetium PSMA group. But when it came to overall survival, there was no significant difference. And again, when they broke down the population in this trial, they found out, as you can see here, the second and the third figure, you'll find out that patients with higher SUV uptake had better RPFS and better progression-free survival, PSA progression-free survival. So we're done with the PSMA avidity. I'm going to move on to a different category, which is microsatellite instability. So the percentage of MSI high patients in metastatic castrate-resistant prostate cancer is extremely low. We're talking about like 1%, 1 minute, inshallah. Keynote 158 only had 6 patients, and pembrolizumab gained approval based on this. This case series, which is actually quoted by the people in UpToDate, had only 9 patients, and a lot of GU-oncologists are relying on this paper when seeing a patient with MSI high metastatic castrate-resistant prostate cancer. I saw 1 patient in my practice throughout those years. He benefited from pembrolizumab. It was a durable response of 8 months تقريبا. واعتقد زميلنا الدكتور صفوان عنده حالة had higher durable responses في جدنا. طيب, we're done with the FDA approved agents. I'm just going to move to non-clinically validated, non-FDA approved tests. ARV7 mutation, which means truncation, distortion of the androgen receptor. A lot of attention was actually gained by this paper when it was first published by Antonarakis, 2014. The take-home message from this paper was that patients with ARV7 mutation in their androgen receptor do not benefit from either abiraterone or will have worse prognosis when you treat them with novel hormonal treatments such as abiraterone and enzalutamide. Those patients should receive docetaxel chemotherapy if fit, because they have better responses with that agent. There are many talks about AKT signaling and PI3 pathway, which gets distorted if PTEN loss was present. I believe breast cancer oncologists have better experience with those agents. PTEN loss is one of the mutations that are present in prostate cancer, but again, it's not clinically validated. This pathway, our agents targeting PIK3 AKT signaling was looked at in this trial and was a negative trial. Ipatasertib and abiraterone versus abiraterone. It did not meet its primary endpoint. There are ongoing trials targeting androgen receptors, such as androgen receptor degraders and ATR inhibitors, CD46 targeting ADC. We'll probably have results of these trials in the next 2 or 3 years, inshallah. By this, I would like to conclude my presentation and thank you all for attending.
Thank you, Dr. Nidar. That was a great presentation. مساء الخير everyone. بسم الله والصلاة والسلام على رسول الله. كل عام وأنتم بخير. Thank you, Dr. Mohammed Al-Garni, Dr. Kanaan, rest of the group, Dr. Hashim, Waleed, Dr. Nidar for the great presentation. And we will continue the learning journey for the rest of the day. So moving from prostate to renal cell carcinoma. For that, I have to, it's my pleasure to welcome my dear friend, Dr. Fahd bin Shamsa, who's going to educate us about the role of immunotherapy in the landscape of renal cell carcinoma, with putting in mind the precision medicine for GU cancer. Dr. Fahd, floor is yours.
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Mr. Chairman, for the kind introduction, and thanks to Dr. Kanaan Al-Shamiri, Dr. Mohammed Al-Garni, and the rest of organizing committee for inviting me and giving me the opportunity to participate in this very special meeting. Thank you, sir. So talk about the role of IO and renal cell carcinoma. So immune therapy and immune checkpoint inhibitors has transformed the landscape of treatment of renal cell carcinoma really completely. That has changed the first line treatment and the early stage treatment, and we will touch on these things briefly, inshallah. So recently they really gained a momentum and presented a first-line treatment for renal cell carcinoma. So we'll start with the early stage, and I will touch briefly on the Keynote 564 study, which recruited patients of kidney cancer, renal cell carcinoma, clear cell, post-nephrectomy, T2 or grade 4 of sarcomatoid, or T3 and any grade. They categorize them in different categories of risk that we'll talk to. So these patients were randomized to either pembrolizumab, almost 500 patients for 1 year, or placebo. So these are the basic characteristics for these patients. Just to note that most patients, 85% were in the intermediate high risk, 8% were high risk, and 6% were M1 NAD. So the study met its primary endpoint, and adjuvant pembrolizumab improved overall survival with a hazard ratio of 0.62. And when you look at the key subgroups in this study, almost everybody actually had the benefit of adjuvant pembrolizumab. The updated progression-free survival also was approved and favored adjuvant pembrolizumab over placebo, with the absolute benefit of 10% after 4 years. Again, all the key subgroups benefited from adjuvant pembrolizumab. When you analyze the study regarding the subsequent therapies, many patients in the second line or subsequent after progression in the placebo, 70% received immune therapy. But really that has did not change the improvement of clinical outcome with adjuvant pembrolizumab. Of course, this will come with some cost and toxicity at the grade 3 or more adverse event in the pembrolizumab were 32% compared to 18% in placebo. So this study led to the approval of pembrolizumab in the adjuvant treatment of high-risk patients after nephrectomy, and it was approved by FDA, and now it's there in the NCCN guidelines. Actually, from last year, we started to look into these patients and recruit them to adjuvant pembrolizumab. Moving to metastatic setting in RCC, it's really the combinations treatment that are now the standard of care after really lots of research from the last 2 decades that led to approval of multiple regimens to select for our patients in the first-line treatment for RCC. These are the NCCN guidelines, where you see we have 4 preferred options in the favorable, 5 in the poor intermediate, and we will touch on them briefly. So we categorize RCC according to the IMDC risk group, and that's because they really their behavior in the course of disease and the response to treatment is different, as you can see from this survival care, where favorable RCC, they enjoy excellent overall survival. I can say no matter what treatment that you give them, while poor risk, they have dismal prognosis. So again, these are the options for the first-line treatment, and these are the landmark trials that led to the approval of the standard of care options: Checkmate 214, Nivo-Epi, Keynote 426, Axi Pembro, and Checkmate 9ER, Cabo-Nivo, and Clear Study, Lenvatinib, Pembrolizumab. Because the populations of this study maybe sometimes look a little bit similar. That's why we do cross-trial comparison. Of course, this is not right, and I will show you why, because the population is not really the same. There are differences in the IMDC group representation, in the sarcomatoid features, proportion of patients, as you can see in this graph, and that's why maybe the comparison is not the best to draw a conclusion to compare, let's say, response rate or survival. So again, there are differences when it comes to tolerability. The treatment discontinuation also was different between these studies, but I'm really against comparing these studies together because they are not the same. Starting with the Checkmate 214, the study was approved, was the first really to come to be a standard of care option for RCC because Nivo-Ipi improved overall survival in the intermediate poor risk group, median 46 compared to 26 only, and progression-free survival also was improved. And you can see this plateau of PFS after the point of 2 years. And that's what we see really in clinical practice of patient response and the maintained response for 2 years. They are unlikely to progress later. Also, duration of response was improved. And we learned from the study because now we have long follow-up for this study, more than 5 years, and we learned that tolerability improves with time, and usually adverse events, they fade and decrease with time. The other study is the Keynote 426, pembrolizumab, axitinib compared to sunitinib. And again, the study, the regimen improved progression-free survival. The response rate now improved. You will notice that the response rate with the immune therapy TKI combination is more than dual immune therapy. Look here, 60% compared to 40% response rate. Also, duration of response was improved, and this is the overall survival. It was improved, the median 47 compared to 40, although after all of this follow-up, hazard ratio is not that impressive, 0.84. You will notice on all of these studies that favorable risk patients, they don't drive much significant benefit. The benefit is mostly for intermediate poor risk, but the response rate is more in favorable risk. The benefit is mostly in survival, and PFS is the intermediate poor risk patients, as you see. The third study is the Checkmate 9ER, this time nivolumab, cabozantinib compared to sunitinib, and again this study improved progression-free survival, doubled really 16 compared to 8, and also overall survival was improved, median benefit with 10 months difference, 46 compared to 36. For sunitinib, again, the response rate was doubled, 56% compared to 28%. The favorable risk patients, again, the benefit was not, the survival benefit was not really clear in this study, despite PFS benefit. Again, the benefit was mostly in the intermediate poor risk patients. The quality of life analysis in 9ER showed favoring nivolumab, cabozantinib over sunitinib. The last study is the CLEAR study, pembrolizumab, lenvatinib compared to sunitinib. And this study, this new regimen, also pembro, improved overall survival with absolute benefit 6%, 66% compared to 60% at 3 years. This is the final overall survival analysis adjusted for subsequent anti-cancer medication, where you see improvement in the hazard ratio of survival. In the this is final OS, in the favorable group, there's no benefit. The benefit is mostly in the intermediate poor risk patients. What's impressive in the study is the response rate. The study reported the highest response in RCC trials, 71.3%. The CR rate was 18.3% with pembrolizumab, lenvatinib. So whenever I have a patient where I need really response rate, patient symptomatic, I will favor or prefer lenvatinib pembrolizumab. Also, the study analysis of association between response and survival showed that if your patient respond and show response, they are likely to show survival benefit. Duration of response was also improved with this regimen as previous trials. So we have these options for our patients. So any other consideration to make to help us to select treatment? If you look at the response rate in this study, maybe the lowest response is the dual IO NAVO-OB. The highest response is pembrolizumab, lenvatinib. So when I come to select treatment for my patients, if I have low burden disease, maybe the dual IO is good to them. But if they have high burden disease, you want response, maybe they are symptomatic, then TKI, immunotherapy, mostly lenvatinib pembrolizumab is the choice. Also, more research on the sarcomatoid features on these trials. They were better presented in the nivolumab study, and the analysis of Checkmate 214 showed marked benefit with nivo-epi in sarcomatoid features with CR rate of 18% compared to 0 and sunitinib. Also, in the nivo-cabo showed also improvement in PFS and response rate and also overall survival. So maybe patients with sarcomatoid features, I will have a preference to nivolumab regimen. So things to influence treatment selection, we have all of these options available. So you look at the IMDC risk group, burden of disease, comorbidity, safety profile of these regimens, sarcomatoid features as we discussed, and prior adjuvant therapy. So in summary, immunotherapy for RCC has tremendously changed the treatment landscape and overall survival for patients, and the use of risk stratification or other risk models may help predict prognosis and guide choice of treatment. And we need to consider characteristics and many factors like risk category and also patient preference, which is really important when we discuss with our patients the treatment options, the dosage forms, to decide among available treatment options. Thank you all for your attention.
Thank you. We'll keep the question at the end of the session. Now, my pleasure to introduce Dr. Ahmed Shandi. He's a consultant in oncology at King Abdullah City and assistant professor at Oncology University. We'll talk about physician approach to investigating cancer. Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Can you hear me and see my slides?
Yes.
Thank you, Mr. Chairman. Thank you, Mr. Chairman, for your nice introduction. I would like also to thank my great friends, Dr. Mohammed Al-Garni, Kanaan Al-Shammari, Shwaq, and the whole team, co-chairs, and also speakers in the GU. I am thrilled to be part of this great event, which takes place annually with the focus on precision oncology and an important topic such as GU malignancy. I have tried my best to cover what we can cover relevant to today's theme, inshallah. Here are my disclosures. And when we talk about the urothelial cancer, the focus is always on the bladder, but we have to keep in mind upper tract is also an important part. Collectively with urothelial carcinoma, they tend to be poorer prognosis, and also the increased incidence of T4 and T3 tumors in the ureter and renal pelvis. So we start by the perioperative therapy. to understand that there are subgroups of patients. We begin with non-muscle invasive and then muscle invasive. But what I want to highlight is the 5-year-old survival in this early disease is around 95 to 100% compared to a third of patients we tend to lose during the muscle invasive therapy. And this can be around 90% we lose when they tend to develop metastasis. So that's important to keep in mind. We would like to expose those patients to the best treatment we have, so we have better outcomes. And an important discovery in the GU, which was almost 7 years ago or 5 years ago, is the introduction of pembrolizumab in the non-muscle invasive component. You can see the complete response reach up to 40%. This is compared also to another important trial, the Atezo, which showed lesser complete response around 30%. But this did not stop investigators to look for newer targets or special nanotechnology to deliver gene within the unresponsiveness of non-muscle invasive bladder cancer. This gene therapy will, at the end, improve the activation of immune cells to target those cancer. And we started to see better survival curves, and at 12 months, we reached up to 40%. This did not stop them from inventing newer superagonist gene therapy with a novel IL-15 superagonist designed to enhance natural killer cell and activation of T cells with cancer immunotherapy. And we started to see complete response reaching to 70%. And this is a great discovery in GU malignancy. When you look at this poorer high-risk prognosis for BCG unresponsiveness, you can see those options are listed in the NCCN guidelines. Unfortunately, this did not translated into the ESMO guidelines. You can see high risk, they still receive cystoscopy with intravesical installation of BCG with also radical cystectomy, but we did not see those reflected in the guidelines yet. So this is one part of the non-muscle invasive bladder cancer. When they have muscle invasive bladder cancer, you know about the story of cisplatin eligibility, and then they receive adjuvant chemotherapy, which was standard of care in the past decades with Gemcis or dose-dense MVAC, followed by cystectomy, and then nivolumab in higher risk group. We have discussed this among us in many GU oncologists, and some of them, when they don't have cisplatin ineligible patients, they prefer to go with cystectomy followed by nivolumab. But nowadays, with the Niagara trial, have showed that addition of durvalumab to standard of care Gemcis in 4 cycles followed by adjuvant 8 cycles led to improvement in event-free survival and overall survival. And this has been reflected in the NCCN guidelines and got the approval on March 28th. So this is a great discovery. We can precisely give to those patients who are benefiting from the Imfinzi. Not only that, the sister of EV, which I call DV, disitamab vedotin plus toripalimab, when we give this in HER2 positive subgroups of muscle invasive bladder cancer, we started to see even better survival. You can see here they're approaching 95% compared to Niagara, which is around 90%. So all of these 2 great discoveries have changed the practice of muscle invasive population with a special target on HER2 population. Now, putting all these together, you can see in the past, we used to have only chemotherapy as a treatment option for perioperative therapy. But nowadays, with different trials, you can see the involvement of atezolizumab, nivolumab, durvalumab, and also many other ongoing trials. All of them have led to improvement in complete response, reaching 40 to 50%. What about the role of adjuvant therapy? We have great 3 big trials, the IMvigor for atezolizumab, the Checkmate for nivolumab, and the Ambassador for pembrolizumab. The only positive trial for this is the nivolumab, which is the DSF improvement, and waiting for overall survival. When you look at the NCCN guidelines, which is something we use for most our patients, you can see it is the preferred and only current medications as adjuvant therapy. I think this will be changed with the use of nivolumab in the next version. Now, because of this theme, I'll be focusing on some biomarkers of today's presentation. Can we predict relapse after radical cystectomy? What we have learned that ctDNA in adjuvant treatment needed. Definitely, you can see here the IMvigor with the atezolizumab. When you have ctDNA negative population, they tend to have better overall survival compared to patients who have ctDNA positive. What about the role of PD-L1 in adjuvant treatment? And you can see that also in Checkmate 274, the nivolumab for all randomized patients with muscle-invasive bladder cancer, you can see it is around 64%. But when they looked at population of PD-L1 more than 1, you can see they increased this number by around 10% at 72%. A recent also national non-randomized Tombola trial looked at the ctDNA-based intervention. And again, we're noticing the same thing. People who have ctDNA negative compared to ctDNA positive, they tend to have better event-free survival and overall survival. Now, in terms of the treatment options for metastatic urothelial cancer, I will not repeat the major discoveries with the Nivo, Cisgem, and ESMO, also the EV, the enfortumab vedotin in first line and second line and beyond, in addition to FGFR mutant urothelial cancer with erdafitinib. But when we put all of these together with recent advancement in management of metastatic urothelial cancer, the best for now in patients who can't tolerate this regimen is the EV plus pembro. When they have disease progression, we can move to chemotherapy and erdafitinib. If the patient is not fit or you have unavailable EV pembro, so we can divide them based on cisplatin eligibility. If the patient is eligible, then we can give Nivo, Gem plus Cis. And if the patient is also cisplatin or carboplatin eligible, and we see good response, then we may add maintenance. If the patient does not have good response or we have progressive disease, then we can add immune therapy, and later on we may add erdafitinib and enfortumab vedotin in addition to other ADCs. A real case scenario can happen within the next few months for most of the cancer centers here in Saudi Arabia. Typical elderly with urothelial carcinoma started to have BCG unresponsive for muscle-invasive bladder cancer. Then later on 1 year started to have metastatic disease. We started the patient on EV plus pembro. Then CT scan showed partial response. We continue maintenance therapy, and we started to see a complete response. This is also reflected in the recent trials where have shown that EV, PO2 subgroup analysis, all of them benefited regardless of cisplatin eligibility or PD-L1 expression. I think the future for the precision oncology in GU cancer is the ADCs. As of now, we have at least 3 or 4 different molecules, such as enfortumab vedotin, ezetimibe vedotin, and also trastuzumab deruxtecan. All of them have different indication or going to have different toxicity. I think this is the future of bladder cancer. Speaking of HER2 positive, as we mentioned earlier, you can see here with the Destiny, the basket trial, you can see median PFS better with those population with bladder cancer who have HER2 positive. The investigators now are looking for combining the ADCs plus enfortumab vedotin, and we start to see some signals with objective response rate can reach up to 70 to 80%. And also ADCs with other combinations such as enfortumab vedotin, sacituzumab govitecan plus pembrolizumab, and also the DV plus toripalimab, and also trastuzumab deruxtecan nivolumab. You can see here objective response rate are reaching 70 to 8%. I think this is the future here. And one word about the biomarkers and precision oncology in this bladder cancer. for almost 2 decades, we know about the ERCC2 and with the cisplatin, and that have shown clearly it's not the best biomarker we can use because the frequency is less than 10%, and also the subtype with dominant subtype, they tend to have less aggressive type and they tend to have better. But the issue here is the intra-tumor heterogeneity and reproducibility of such biomarker. What about the role of TMB? You can see more or less are the same, and p-value is not significant, and the pre-existing T-cell immunity, again, we don't see much difference, so this did not help us. Also, for the bigger trial, the EV-Pembro, Tom Powles have shown that this marker is present more than 90%, but in his paper, he showed EV-Pembro works great regardless of the Nectin-4 expression. I think the next in GU cancer, similar to other cancer, is the ctDNA, as all trials here, which were small, but giving us the hypothesis of generating ideas and approval of these concepts. After radical cystectomy, if you have ctDNA negative, they tend to have better outcomes compared to positive outcomes. Similarly, the prognosis and disease burden, when we have less ctDNA positive, it shows that it's different when they tend to rise and cause metastatic disease. Again, low ctDNA, they tend to have better survival compared to higher ctDNA. We just mentioned a few words about IMvigor, and again, we are seeing the same overall survival better with ctDNA negative compared to ctDNA positive. It's also replicated in other trials by and presented by Powles. Again, the ctDNA negative have been showing better disease-free survival and better overall survival. Now, the argument we have with many GU oncologists is, can we give adjuvant immunotherapy to all patients or only people who have ctDNA positive? Because when you have somebody with ctDNA negative, you tend to have almost 100% survival benefit. So this is something will be discussed further with many prospective trials to reach out the best answer. At the end, I think a combination of perioperative durvalumab plus cisplatin chemotherapy is the new standard of care. Adjuvant immunotherapy with nivolumab now is a standard of care in high-risk population. Biomarker selected or personalized therapy, and trials are on rise. ctDNA is promising, and newer trials will guide us as oncologists. With that, I conclude, and thank you.
Time and that question session. And so we move to the last speakers. The last speaker is Sam Asleman. Sam Asleman is a consultant at Kingston City, and update on
Yeah, thanks, Dr. Hashim, for the introduction, and also I would like to thanks to Dr. Kanaan and Dr. Garni for the invitation for this annual conference. Now, I would like to congratulate them for this fifth annual meeting. In my talk in the next 20 minutes, we'll talk about the gyno-oncology and what's the target therapy updates in this era. I think gyno-oncology for a long time, chemotherapy based, for a long time chemo and hormonal, and now in the last 5 years it started to be PARP inhibitor, and recently in the last 2 years immune therapy and ADC start to have a role in gyno-oncology. So I will start with the immune therapy, how the immune therapy in gyno-oncology cancer and how or when we'll use them. So for a long time, for the last 2 years from now, I present my talk here about the update in gynecology, and at that time I'm speaking about immune therapy in endometrial cancer as a second line. In the last 2 years, multiple trials assessing the role of combination IO with chemotherapy versus chemotherapy alone as a standard of therapy. Multiple phase 3 trial. We have the DOE testing adding the durvalumab, the first trial here. The NRG GY18 testing adding Pembro to the chemotherapy, and the ROBI for dostarlimab. These 3 trials testing the immune combination of chemotherapy with the immune checkpoint, and it met the primary endpoint in all of them, the progression-free survival. There is 2 of these trials assessing the role of adding another target therapy, the PARP inhibitor or the vascular growth factor inhibitor, to the immune therapy with or without chemo. So we have in DOE, they add the olaparib, and the ROBI, they add the niraparib. And the last trial, the one in the last row, is the LEAP-001, the idea of combining Pembro with lenvatinib, the TKI, or the vascular growth factors, versus the chemotherapy in the deficient MMR patient, and sorry, in general population. The primary endpoint is progression-free survival, and the result showed is negative to be superior over chemo. But the other combination using IO with chemotherapy, all of them they met the primary endpoint. Just here I highlight the difference between these trials, that all of them they include patients with measurable or evaluable stage 3 or 4. Some of the trials they allow non-measurable stage 4 also to be included. The different histopathology, clear cell, serous, and carcinosarcoma, except the GY18, the one with Pembro didn't include carcinosarcoma. And the progression-free survival or the progression-free interval from last chemotherapy or last therapy was different between the trials. The ROBI and ATTEND, they have the 6 month, and the other DOE and GY18, they allow for more than 6 months for a progression-free interval. All the 3 trials, the ROBI, the GY18, and the DOE, met the primary endpoint of progression-free survival, which you can see here the hazard ratio 0.3 in all of the 3 trials. Also the overall survival was met here in the ROBI part 1 with hazard ratio 0.3, especially in deficient MMR population. The median reach with adding dostarlimab to the chemotherapy reaching to no median of reach for the overall survival, but compared to the chemotherapy arm is only 31 months. And you can see here the guidelines now. The recommendation is to adding the immune therapy to the chemotherapy for the patient with advanced or recurrent stage of endometrial cancer, adding pembrolizumab with a carbobacli or dostarlimab with carbobacli. And we highlight here for the patient under durvalumab, the third option. Moving from endometrial cancer to cervix cancer, what's the IO update here? We have it we know it for a long time that the chemotherapy backbone for metastatic cervix cancer is platinum with taxane, with a median overall survival of 13 months. Once we add the vascular endothelial growth factors, it's improving the overall survival to 17 months. And with adding now the third regimen, the fourth regimen, or the fourth drug, it's the immune therapy to the BEPA and chemo, it's increasing the median overall survival to not reach almost now 24 months in all comers. So the result of that, we presented before, it's a keynote 826. It's assessing the role of adding Pembro to the old standard, which is chemo with bevacizumab. And they assess the PD-L1 status on all the patients. So they are giving the chemo-immuno for 6 cycles, then they continue the pembro for a maintenance therapy. The dual primary endpoint is the overall survival and progression-free survival. The progression-free survival for the intention to treat is positive, as you can see here. The pembro is 10 months versus 8 months. With adding once we add the pembro, it has a ratio 0.65, and the PD-L1 positivity had the same result, but the FDA had the approval only for the patient who had PD-L1 positivity, because if you can see here, this is the response or overall response rate when adding the pembro to the chemo. It is almost 15% addition to the chemotherapy alone. And we can here see that in the subset analysis for the patient with PD-L1 0 or less than 1, and the progression-free survival and overall survival, no benefit from adding the pembrolizumab, and that's why the FDA restricted their approval for the patient with PD-L1 positivity. The good thing that in cervix cancer, most of the patients, they have PD-L1 positive, almost 80 or 90%. Moving to the recent update in cervix cancer, which is once the immune checkpoint inhibitor had its work in the metastatic setting, why not use it in the locally advanced with concurrent chemoradiation? So, and we have the result from the GOG 3047, which is assessing the role of adding pembrolizumab to the standard concurrent chemoradiation. So this is the design of the trial. They include patients with high risk, locally advanced stage 1B2 and 2B2, and also patients who had cervix cancer stage 3 and 4A. There's 1,000 patients, and the primary endpoint is the progression-free survival and overall survival. The co-primary endpoint, we can see here that from the keynote A18, there is the progression-free survival is positive with hazard ratio 0.7. The median net reach for both arms, for the placebo and the pembro, and you can see the rate of progression-free is 68 versus 57 once we add the pembrolizumab. And the second term analysis, we will have this continuing the same result with longer follow-up. And the result for overall survival, sorry, before overall survival, here the subgroup analysis for the progression-free survival, we can see here that the main benefit from adding pembro is in the advanced stage, in stage 3 and 4. But in stage 1B2 and stage 2B2, the benefit of pembrolizumab is not there for in terms of progression-free survival. Looking for the overall survival, we can see here there is improvement in overall survival with hazard ratio 0.67. At 36 months, the rate of disease alive is 82 versus 74%. And the same, that the benefit of overall survival is mainly in the advanced stage, stage 3 and 4. Stage 1 and 2 didn't have a benefit from adding the pembrolizumab. And we can see here the recommendation by the NCC guideline that adding the pembrolizumab and the chemo with the chemo radiation, especially in the patient with category 1, for the patient with a stage, a local advanced stage, either with cisplatin or with carboplatin, regardless of the PD-L1 positivity. Moving to the metastatic setting on the right side, the pembro, for patients with PD-L1 positive, so it's required to have PD-L1 positive to add pembro to the chemotherapy plus minus bevacizumab. Now moving from the immune checkpoint to the PARP inhibitor, no update on that in the last years. We know that ovarian cancer now for more than 5 years, that it's not one disease. We have different subtype or subgroup of the high-grade serous ovarian cancer. We have to test for the BRCA and for the HRD, and we classified the patient based on that to be 50% of the patient HRD positive and HRD negative, and the BRCA positivity is representing around 30% of the patient, either germline or tissue. This is explanation how the need for assessing the HRR or the HRD in ovarian cancer patients. So the trials as assessing the PARP inhibitor, the target therapy in ovarian cancer, we have 3 well-known trials. We have the PAOLA one, which is assessing olaparib with bevacizumab. The second one is PRIMA with niraparib, and the last one is the rocaparib, the Athena or Athena mono. But all of these, and we have the olaparib as the SOLO-1 trials. All of these trials, here we can see it, they met the progression-free survival once we add it as a maintenance therapy after the chemotherapy, either olaparib, niraparib, or rocaparib, especially in patients with the BRCA or HRD positive. The only difference from this trial is the PAOLA one, who is assessing using the PARP inhibitor with bevacizumab versus bevacizumab with, as a maintenance therapy. Moving now from PARP inhibitor, because since we don't have any updates, there is some trials assessing the role in the ovarian cancer about adding the immune checkpoint, but it's fair to show clear benefit over the PARP inhibitor alone. Now, moving to the antibody drug conjugate in the gynecology cancers, we can see here different ADCs tested in gynecology. We have the most 2 things is targeting the folic acid receptor alpha and the HER2. This is the most 2 targeting. The last one is TROP2. Also, there is a lot of trials assessing the TROP2. We know now the ADC moving forward in oncological management because they have a high affinity to the tumors and less toxicity compared to the chemotherapy. And once we see the gynecology cancer, how the expression of these targets, we can see that the cervix cancer had more HER2 and more their folic receptor alpha, and also the ovarian cancer more of tissue factors. There is some ADC targeting the TF, and for the endometrial cancer, is more of folic receptor alpha and the HER2 and TROP2. I will talk in the next 5 minutes about the approved ADC in the gynecology malignancy, which is 3. The first one is the mirvetuximab sorafenib. It was studied in a phase 3 trial. It's called MIRSOL. I will present it now. The MIRVA is targeting the folic receptor alpha, which should be 2+ level membrane staining tested by immunohistochemistry. The linker here is the sulfa SPDB. The payload is DM43. The main toxicity of MIRVA here is, you have to watch it, is about the ocular toxicity, which is representing around 60% of the patient, and pneumonitis is 10%. The second ADC, we'll talk about it in the tisotumab vedotin, tested in a trial is INNOVA TV301. The target expression of TF here, tissue factor, and the toxicity is almost the same, but the difference is the ocular toxicity and peripheral neuropathy, but no less of incidence of pneumonitis. Last one, we know it all, the trastuzumab deruxtecan, tested in multiple trials. I think the one well known is the PanTumor02 trial, phase 2 trial, targeting HER2, and I'm not listing here the adverse event. So let's see the 3 trials. The first one is the Destiny PanTumor02. They included multiple tumor. The three first tumors, as you can hear, the response, the objective response is the cervix. You see here remarkable response for the cervix patient with HER2 positivity, and endometrial cancers and ovarian cancers. Patient who had HER2 expression with gynecology, regardless of cervix, endometrial, ovarian, I think TDXT, it can be used for them. And we have some trials assessing the patient with uterine carcinosarcoma which you can see here in the diagram for patient HER2 positivity. Even in the HER2 low, the benefit is there on phase 3 trials, sorry, in phase 2 trials. Moving to the other ADC is the MERFA. The MERFA, they tested in Mirasol trial, specifically for patient platinum-resistant ovarian cancer who had the folate receptor alpha high by immunohistochemistry, and they randomized to either MERFA versus the physician choice chemotherapy, paclitaxel or liposomal doxorubicin or topotecan. And the primary endpoint is progression-free survival. As you can see here, the result is positive by improving the progression-free survival with hazard ratio 0.65. The median improved from 4 months to be 5.5 months. And the overall survival also improved with hazard ratio 0.67 from 12 months to 16 months. So by this, the Mirasol had met the FDA approval for that. Last ADC I will talk today is the tisotumab vedotin and cervix cancer. They include patients who had recurrent metastatic cervix cancer who progress on chemo with beta and immune therapy, if eligible for the immune therapy. And they randomized them to either tisotumab vedotin versus chemotherapy single agent. And the primary endpoint here is overall survival. And the result is met the primary endpoint, the overall survival. You can see at 1 month, and at 12 months is 48% alive versus 35 with hazard ratio 0.7, which is statistically significant. Also, the progression-free survival is positive here. So as you can see here, the NCC guideline for the ovarian cancer recommend the ADC MERFA, and for the platinum-resistant ovarian cancer, who's having the folate receptor alpha expression tumor 75% or more as category 1. The second thing is the endometrial cancer, listing the TDXD as a HER2 positive as an option, and the cervix cancer, listing the HER2 positive for TDXD, and for the patient with the as a subsequent line, the tisotumab vedotin as category 1 for the patient who progress on chemo, immuno, and bevacizumab. So the key takeaway from my presentation that we have multiple novel agents now targeting molecular markers specifically for the gynecological cancers, immune checkpoint inhibitor, Pembro, dostarlimab, durvalumab, enhance the immune response to endometrial cancer, the antibody drug conjugate, the TV, the MERFA, TDXD, all of these combined target delivery with the potent cytotoxic potent cytotoxic effect with less cytotoxicity to the patient. By this, I'm concluding my presentation.
Thank you, Bassam, for this very nice introduction. So please all the speaker to the podium. So let's have a discussions, and maybe we'll start the questions from the audience. Dr. Walid.
Thank you for all speakers for excellent talk. I will start my question to Dr. Sam. Thank you, Sam. For a patient, I have 2 questions. The first question, you are mentioning the TDXD in cancer cervix. That's not our common recommendation to do HER2 testing for patients with cancer cervix. Question, when we request HER2 testing, goes first question. Second question, for whom you will give for patients stage 3C or stage 4, totally resected, there is no disease, and MSI is progression. You recommend for those patients to give adjuvant chemotherapy with immunotherapy or only just chemotherapy?
So we'll start with the first question. The cervix cancer.
It's working.
Again, the cervix cancer, I think that this is aggressive disease, and we have limited option and taking this cancer, and that's why we are using the first line for regimen therapy. And once progress, have limited option. I think we have to start since we have the result of having a positive patient to test they have to or all metastatic settings now. Other the TB limit not available unfortunately and limited access. And I think for these two reasons we have to do better to all the patients for now. Regarding the second question, endometrial cancer, the question, the endometrial cancer who has cytoreductive surgery, stage 3, and the question is to use about that concurrent chemoradiation with chemo or chemo immuno.
So, adjuvant. That's only adjuvant, assisted, and then for MSI profession, I would give adjuvant that's so carbo chemotherapy standard of care, or will add immunotherapy based on the evidence?
Yeah, we have the keynote B21 assessing the role of adjuvant pembrolizumab in endometrial cancer, and the result for intention to treat were negative. So our next in the subset analysis for the patient, they have a benefit from with adding pembrolizumab, but because the study was designed to assess the intention to treat population and it's negative, so that's why the trial is considered negative. In NCCN guideline, they mentioned in the below the table that we can consider it for deficient MMR. For patients with deficient MMR, high stage, disease, and adding also with the ROBI trial for stage stage 3C1, they with no evidence, sorry, stage 3C2 with no evidence of disease after the surgery, there is a benefit from adding the from all of these evidence, I will consider it, but for only the patient not for the profession. And for the patient with high advanced stage, stage 3, stage 4, stage 4, these patients
Yes. Okay. Thank you very much, Bassam. Any further questions? Abdurrahim.
Bismillah. Thank you, my dear friends, for the great presentations. I have a question for each of the GU speakers, and usually it's about the sequencing, starting by the first presentation that awesomely presented by my dear friend, Dr. Ridwan. Two questions. The first one, it's congrats for using talazoparib in your patients. And what was the side effect? Is it the same that's reported with the fatigue and hair loss, or was different with our patients? The second question, which is my main question, now with those MSI high, I know it's a very low proportion. Do you use pembro for those patients when you exhaust all line of treatment, or you prefer to do it earlier?
So, that me wrong. I actually haven't used. I didn't have the luxury of using elazoparib enzalutamide. The only partners I used is Labrib so far, in less than half of patients. And you probably know the side effects of Labrib. Some of my toxicity, sometimes patients. Elazoparib I haven't used. With regards to the second question, even though it was an experience of one patient, this guy had a very aggressive presentation. He was 42. Prostate cancer patient I've seen in Saudi Arabia. It's so quick. And he presented to me before the era of triplet, basically. And I actually started pembrolizumab in the second line setting. And he had a durable response, which was close to what the series mentioned. However, one had a better experience. I think this patient lasted for almost 2 years. I would use it Unfortunately, after progressing pembrolizumab from many NHTs, and he had a very short response to what we see afterwards. Why? I hope that answers your question.
Great. Great. Thank you, Dr. Nadar, for the clarification for the good answer. I agree with you for the second line. Moving to the second presentation with renal cell carcinoma, Dr. Fahd as well greatly presented the data for immunotherapy. And now with pembrolizumab coming earlier in the adjuvant setting, for someone who recurred after 2 years, do you prefer to use a different agent like nivo-capo for the first line for recurrence, or you want to reintroduce the thing that you work with you like pembro?
Thank you, Dr. Ibrahim, for this important question. And we're starting to use adjuvant therapy. So we will be seeing those kinds of patients and treating time to think what are our options. Progressing after 2 years of completing the treatment with adjuvant pembrolizumab, I think maybe all options are kind of important to me. I will work into other factors. Now he is lapsed with sensitive patients. So again, I will use the patient preference, dosage forms, the disease burden, symptoms. In general, I would like to introduce new patients in terms like for exposure to other people. We know they are all ICI, but you want to try something else, they're not identical. So I will have some preference to change the immunotherapy. But I will look also into other factors like age, performance, preference,
Yeah, I will add to that, Fahad, to that question. So, in addition to this classical, criteria to choose in of therapy and metastatic RCC, do we foresee any upcoming specific biomarkers helping us to choose the options of therapy, IO, or IO TKI?
Thank you, Dr. Hassan. This is really a very, very important question and something I think it's ongoing research to have a real precision medicine to help us to select treatment. Yet there is no clear biomarker to guide us for this treatment or the other. And that's why we use these clinical, let's say, guidance from subgroup analysis, from studies. Yet there's no clear biomarker to guide us. That will be really important and will have a great benefit of treatment selection. You know, these agents, they don't come without side effects, they don't come without very significant cost. So I would really, as a clinician, I want to know which patients or which treatment.
Okay, thank you. Abdurrahim?
Yeah, so moving to the, thank you for the answer as well, Dr. Fahad, and moving to Dr. Imad. Bladder cancer is now the main, all the light now on bladder cancer with many treatment, or the treatment in the first line, speaking of EV, enfortumab vedotin. And all GU oncologists, I know your opinion, most of you, about the use of cisplatin, gemcitabine, and we all like platinum pro before this era. My question, for those who were with FGFR mutated patient that we usually think of the second line or third line, if they received EV in the first line, do you prefer to give platinum in the second line, or you jump to targeting that mutation?
Well, this is a great question, Ibrahim. In fact, I would guide my therapy based on the response. So if the patient has good response to first line treatment and he's doing great, I would go with the dafatinib. If the patient is rapidly progressive, then I would give chemotherapy.
Thank you. Back to you, Dr. Hisham.
Thank you, Abdurrahim. So, any further questions? So, I have final questions here, maybe for all of you. So, what is the barrier you see for implementing precision medicine in our practice here in Saudi Arabia? So, who want to pick up that?
Maybe I would start. I think my colleague will agree one point. I think accessibility to do tests to precision medicine is a barrier. I thought myself that access to NGS would really go quite rapid to do. I was thinking that in 1 or 2 years I will be able to do NGS for most of my patients. But really the cost is not reduced significantly, and the access is an issue to, I know there is variation to distribution, but at least to us, it's a significant barrier. And the other thing is the lack of evidence. We know we base our guidelines on phase 3 randomized trials, but many of these the same mutations, they are rare, and you never have the phase 3 study. That's why they don't show on the top in the guidelines, so you will have difficulty approving the treatment in your institution. I would like to be in that era where we do mutations and we do more to discuss the treatment with the access. But really the approval, the ETS, and the
Yeah. Bassam, any addition?
I'm agreeing with Fahad that the main issue is the availability and limited access to these tests, depending on third party for supporting to get access to these tests. I think this is the main challenge.
Okay. And Nidal, how to overcome these challenges?
So if you want me to answer the prostate cancer part, I think they're okay. However, I would agree with Dr. Bassam and Dr. Fahad. I would really like to see good NGS testing technology.
Yeah.
So I hope so.
Great.
Thank you so much.
Dr. Imad, any addition?
Well, I'll talk about it from a different angle. We do have a great country. We do have great patients. We have a lot of money. We have outstanding oncologists. But we don't have a goal. If we put this as a goal, I think we can reach it. Thank you.
Yes, I agree with you. Okay. So thank you very much. So here we will conclude our sessions, and I will give the mic back to Dr. Kanaan and Dr. Mohammed. Thank you.
Thank you very much. So this is the end of our conference. I'd like to take this opportunity and thank all speakers, moderators, our 1,000 virtual attendees, and a special thanks to our sponsors. Also a special thanks to our organizers, Mohammed Khayyat, Jason, Hanan, and everyone who helped make this conference successful. It would not have been successful without all of you. And we definitely look forward to welcoming you to our next year's Precision Oncology Conference. Thank you and have a great rest of your day.
Dear audience, thank you all for attending these two informative days. We wish that you gained new knowledge and you enjoyed the learning. We would like to draw your attention that all of the meetings materials, pictures, and recordings are available on our app. Please make sure to download it, add it to your home screen, and you will find all the materials there. Thank you very much and see you next time. And by the way, next event will be advertised through our app. Thank you. Wassalamu alaikum wa rahmatullahi wa barakatuh.